Well, welcome everybody to today's Children, Adults, Health and Wellbeing Policy Development and Scrutiny panel. It's lovely to see so many here today as we're coming to just a few minutes earlier. Perhaps it's because it might be the only dry space in the city at the moment, although it does look quite pleasant outside now. So what I would like to do, I will go around the room so everybody can introduce themselves so we know who is who in this meeting today. So my name is Dina Romero and I'm the chair of this meeting. Liz.
Good morning, my name is Liz Hardman. I'm the vice chair of this meeting.
And for the rest of the panel, if you could just indicate whether you're a voting member or not, that would also be helpful. Michelle.
Good morning, I'm Michelle O'Doherty, Councillor for Newbridge Ward, and I'm a voting member of the panel.
Good morning, I'm Ruth Malloy. I'm a ward member for Weston, and I'm a voting member of this panel.
I am Joanna Wright, ward member for Lambridge, voting member.
Hello, I'm Alex Beaumont, voting member, Councillor Keynsham North.
Paul Crossley, voting member and South Down ward councillor.
Thank you, Paul. Kevin.
Good morning, Kevin Burnett, Professional Association representative for the NAHT, non-voting member.
Chris. Thank you. And Leslie.
Hi, my name is Leslie Mansell. I'm the ward councillor for Radstock and I'm a voting member.
Thank you. And I'll come to everyone else in a moment, but if I ask Kerry and then Mark to introduce themselves.
Morning, Kerry Williams. I provide the scrutiny officer support for the panel.
Good morning, everyone. My name is Mark Downford. I'm the Democratic Services Officer for the panel.
And I will now start with our newly arrived Cabinet member.
Thank you, Chair. Sorry I'm a bit late. Paul May, I'm the Cabinet Member for Children and Young People.
Thank you.
Well, my name's Lucy Baker. I'm the Director of Learning Disability and Autism and the Deputy Place Director for BSW ICB. Apologies for the long title. I'm here today representing Laura Ambler.
If I'd been very unkind, I could have made you actually go through every one of those acronyms. Alison.
Good morning, I'm Alison Braun. I'm the Cabinet Member for Adult Social Care and Public Health.
Suzanne.
Suzanne Westhead, Director of Adult Social Care.
Jill.
I'm Jill Kirk. I'm the Labour Group Assistant.
Hi there, I'm Paul Scott. I'm Associate Director of Public Health here at Baines Council.
Hi, I'm Teresa Ray Daniel. I'm from the University of Bristol.
Hi, I'm Rebecca Wilson, also from the University of Bristol.
Hello, I'm John Banks. I'm also from the University of Bristol.
Hello, and I'm Becky Reynolds, Director of Public Health and Prevention.
Thank you very much. Have I missed anybody? Oh, well, it's very lovely to welcome you all to this meeting. I'm now going to pass over to Mark, who will tell us what to do if there's an emergency.
Yes, thank you, Chair. So, if the continuous alarm does sound, you must evacuate the building and proceed to the assembly point. From this room, you follow the green running person signs to the exit, using either the marble staircase or the main staircase. Please do not use the lifts. The assembly point for this building is the Orange Grove grassed area just outside Brown's Restaurant. There is an evacuation chair for use by disabled people who so wish in the corridor outside the Council Chamber Public Gallery. Alternatively, the area at the top of the marble staircase has been designated as safe refuge where persons needing assistance should assemble. Thank you, Chair.
Thank you very much, Mark. Okay, so the next item is apologies for absence and substitutions. I have one apology so far, which is from David Harding. Are there any other apologies?
None I'm aware of, Chair, no.
And the only substitution we're aware of is obviously Lucy for Laura Ambler. Thank you. Okay, right, declarations of interest. Any declarations to make? Okay. And urgent business, I've not been notified of any urgent business. Public or councillor statements and questions, again, I've not been notified of any. And now we are on the next item, which is the minutes from the 11th of March. So, can I have some indication of any errors or omissions or any corrections that need to be made? Kevin.
Thank you, Chair. First one is around under accuracies. Both myself and Chris Batten weren't marked as present in the last meeting. The second under accuracies is page 5, item 99. A statement was from the Chief Executive Officer of one of the MATs and not a chair of a trust. Page 6, item 101, I raised the point that Chris hadn't yet got back to me regarding the safeguarding process question. And page 8, after I was asking about the aim of the education summit, or the summit in Bath University, Chris kindly offered to send around a summary of the outcomes for education from the summit.
And that's almost waiting for that.
And sorry, the last point under accuracy was page 18. I think it's supposed to read after the an application put before a multi-agency panel that the LA need to see a robust record of what the school has done before the application can be processed in the HCP process.
Thank you, Kevin. And I know that David Harding did mention a different emphasis. I think it was on page 6 for patient and well-being, as this was a slightly different emphasis that he had been stressing himself. But I'll ask him just to confirm what that was. So with those various corrections, is everybody happy to sign these minutes off? Okay, all those in favour? Good. Right, now we move on to the Cabinet Member update, which has been circulated. I don't know, Alison, if you've got anything further you wanted to add to that, otherwise we'll move straight into questions.
No, I don't really have anything to add. I'll assume that everyone's read it, and it's basically a summary of the actions across adult social care and public health since the last time I was here, and it provides an update on several of the things that we've discussed in this meeting. So I think it's probably easiest if we just go straight to questions and discussion, if people are happy with that.
Right, Kevin.
Thank you, Chair. Thank you for the report. Can I just, on the outcome of the budget consultation, which is obviously welcome, that you will further discuss where and what things will happen, will the reports on the consultation with community partners be coming to panel? What are the key stages of the consultation, and any timeline for the review that you have in mind at the moment?
Yeah, I mean, we've started the process. Obviously, it's quite a comprehensive process, because we haven't been directly managing a lot of these contracts for the past 7 years, because they were included in the Virgin Care and then the HCRG contract. So for that reason, it's important, before we make any decisions about them, that we review and have a really thorough understanding of the contracts and what they're delivering. So that is one stage of the process. And another stage of the process is to draw up service specifications for the services that we wish to recommission. So those two pieces of work are starting. Now, to have the new contract, we really need to have completed those pieces of work by September in order to do the recommissioning. So that's the deadline that we're working towards. It is a challenging deadline, but that's what we're working towards, and I will certainly be aiming to keep this group updated throughout when we have bits of information that we are able to share. I suppose the other thing to say is that actually we have found additional funding to manage any savings over a 2-year period, so we are not under the pressure that we thought we might be to make short-term savings.
So I'm just checking if Kevin had another question. Okay, Liz.
Thank you, and thank you, Alison, for your report. This question actually directly leads on from what Kevin was saying, in that with the budget consultation, with the proposed cuts of £802,000, a new strategic board has been set up by Mandy Bishop, who's Chief Operating Officer, to provide leadership and oversight involving our community partners. There's going to be proactive engagement with the community, as you have said, with our community partners, which will be at the heart of this. I'm quoting from your report. But the next phase of communication is planned in mid-April, and could you explain what do you mean by this next phase of communication? Thanks.
Thank you for that question. At the moment, we will plan to go through a procurement process, but before we start the procurement process, we will be doing engagement over May, June, July. Well, we've already started April, May, June, July, and as Alison has said, it'll be September before we're probably likely to have a specification. So the next 3 or 4 months are really important. So what we're doing firstly, and we're doing it actually right now, is we're doing a review of all of the partners with the partners. So we're just about to go out and write to them, explain to them about the review. Then we'll be working with them on the principles of what we require from community partners and what they think are the important areas as well. We'll then come out with a specification. I would expect to have that ready for September. Then we go straight into procurement and then an implementation stage. Now that time frame is very tight, but I do think we've got contingency if we don't make it, say, on the 31st of March. We have great community providers and they've engaged at every level, as you probably know. So it's important that we get and hear from them, but we need to hear from the whole group, not just the smaller providers or the bigger providers. We need to hear from everybody. So we will have events planned over the next number of months, so that September we've got a specification to go out with.
Supplementary, I know there are other people who actually want to ask questions, but with the statement on community support contracts that you've just mentioned, there are about 70 of our community partners. I mean, can we be reassured you're going to look at this, you're going to draw up a contract with them before you go ahead with the next phase? Will there be any cuts? I mean, are you looking at these community partners with regard to, as you said, you've not been involved before? Will this be the start of looking strategically at which areas you're not going to continue with? I wonder, could you reassure our residents that we're not going to see cuts before the coming 12 months?
So first of all, remembering that all of the contracts are still with HCRG. They're still with HCRG, and we're working through HCRG as a commissioner. As you've seen in the consultation, the finance consultation document, there's 802k savings up against that. And we're trying to make sure that we do that in a measured way. I'm not expecting any other savings. We'll need to work with the providers in the community about how to achieve that in a safe way. I do think there's opportunity, and I think probably the sector would say this as well. There's an opportunity to get more for our money, because we get quite a lot already, but we've added stuff in over years, and some providers are duplicating, they would say. So we need to look at that, but our key principles will be around the Care Act. So we'll be looking at carers, we'll be looking at integration, we'll be looking at early intervention, and we'll work with what the key principles are for the contract. But once we get to a position of the key principles in the work, then we'll have to go into sort of a closed environment because of a big procurement. but there isn't any other plan on top of the 802 right now.
Thank you. Leslie.
Yes, thank you for the report. I wanted to ask about the care experience young people. I'm sure everyone in the room is really pleased that the last council did pass a motion unanimously regarding including this as a protected characteristic. Could we have a review of that in 6 months to see how it's being implemented?
I would imagine that's more of a question for the Cabinet Member for Children's Services, but luckily he's here and has heard that and wishes to respond.
Yes, thank you, Chair. We're doing a lot of work already to try and widen it out beyond the council, and I'd be more than happy bringing a report back to the next meeting rather than 6 months, because I think there's a lot happening, and I think we should be proud for our young care experience young people.
Thank you. And possibly we could bring in some sort of national picture as well, because I'm aware that a number of other councils have now taken on this sort of ambition as well. Thank you. Joanna.
Good morning, thank you. Just following up from what you've said, Susan Westhead, about better services and about how some of them are overlapping. In my experience of talking to some of the providers, they actually felt that they were in a terrible, dire situation as it was, and the cuts were going to cause them further problems. Might you actually find from this strategic board that actually we might need to invest more money than we're already investing? Might it be not the case that we're in a situation where we have to make cuts, but that actually we need to increase the funding that we're delivering?
Okay, yes, I mean, the providers have had flat cash for the last 7 years. So it's understandable that they're saying, you know, it's difficult. But on the other hand, there have been some changes, as Suzanne said. Some new services have been added in over time, and certainly the discussions I've had with providers is that they feel that there are some areas of overlap, and you could do some streamlining so you don't have lots of different providers providing the same service. You have a provider. So I think by being more strategic, it should be possible to get rid of any any overlap and and that should enable us to make savings, which will allow us to target our funding better. However, we have also said that when we do the review, if it's clear from doing the review, but by making savings, it will actually cost the council more in other ways, then we are committed to not making savings in those cases. So, we are going into this with a genuinely open mind, while at the same time having at the back of our mind a saving target that we are aiming to make, but we won't be making any decisions until we've done the review and we've got a full set of information to base them on.
And how will you be relaying that review to us?
We haven't actually discussed that yet because we haven't completed it. We haven't even started the review, but it may be that in our agenda setting that might be a plan that you'd want to see. So when we get to the piece of work with the providers, we've done the engagement, we've set the joint principles, it could be a good opportunity to bring it back here through scrutiny. And that would probably be around, let's say, I would say July, August. When we'll be ready to do that, because we really want to have meaningful engagement. I don't want to say we'll do it any earlier than that, because if we get out for specification in September, we should have the next number of months doing the engagement and making sure we've got the key areas of work that we're going to work on with the providers. We could do through that if that's what the panel would like to say.
Well, I was just thinking we do have a paper coming in June on an update on the transformation. So perhaps, if nothing else, we could have an update at that point. But take on board the point that you're making about the need to maybe do more work and actually have a more comprehensive report later on. Joanna.
I would encourage that we are taking part in the process.
And as ever, that point is well made, Joanna. Ruth.
Right, thank you for your report. Just one thing in particular was interested about the oral health amongst children, and I had a question. It's being delivered by At Home Dental, and you've written that to date 63% of eligible schools have signed up, but is that in the whole of the Southwest, or is that with reference to Bath and North East Somerset? And could you tell us which schools locally have signed up to that, please?
I'm going to defer that to Becky, who I think will have the detail.
Right, thank you.
Yes, thank you. Thank you for the question. So in Baines, we've got 18 primary schools and nurseries that are eligible. So we've written out to all of those, and we've got 13 schools that have responded and are participating. So that's 72% of the eligible primary schools participating. And we've got 3 schools that have declined, and we've got 2 schools and nurseries that have not responded. So it's quite a good uptake rate. So we've got 13 schools and nurseries participating out of the 18 eligible, and we've also been able to add the 2 special schools as well into that. So they've also now come on board in addition. So in total, we've got at the moment 425 children in preschool and reception participating in the scheme. And the scheme lasts over 2 years. It's a 2-year scheme with daily toothbrushing in the schools and the nurseries.
Up question of those 13 which have accepted to take part, are all the primary schools that are being supported by St John's Foundation among those?
I don't have that information on me, I'm afraid, but if it's useful, I can find it and get it to you. But we are working very closely with St John's on it.
Yeah, thank you.
Thank you.
I think that would be useful information because I know St John's are working with the most disadvantaged schools, so it would be very, very relevant. And I also would be interested in the reasons why 2 schools declined to join in as well. I think that would be very useful to know and see how we can challenge or perhaps encourage them to take part.
I'll look into that and get what information that we have back to you.
Thank you. Kevin.
Yes, thank you. Sorry, are we on public health update questions as well? Because I've got separate ones to those. But
I think this is all part of the Cabinet members'
update,
update,
okay.
so yes.
Bless you. Well, just going back one step, if I may, just to the voluntary, what the voluntary sector does and how it operates. There was discussion a while ago now in panel that there might be a paper coming forward about what the voluntary sector actually does, how the voluntary sector engages with the local authority, and how the voluntary sector supports local authority services. And I just wondered whether, as part of all the work's being done at the moment, that clarity might come out at the end, that we actually can see what voluntary services are there, what they do, how they engage with the local authority and how they support local authority services, so that we have a reference point to come back to at any point in time, because it's still an amorphous mass out there of what they do and how they're doing it, because there's so many people involved in it. And just one very quick extra question around the Cabinet Members' report around the Charlton House providing meals at the moment. Presumably that will continue in a same form, a different form when it changes to residential? Or?
Regarding Charlton House, they provide meals to, there's a number of people in and around Charlton House which we support. So they provide meals there, and also into Hawthorne Court, which is on the same site. There's a 30-bedded extra care unit there, and that will continue on. The site will continue to be developed as a community sector in the same way that Cleeve Court is now. So yeah, it will continue. And the other question you asked was regarding the third sector. 3SG, and we need to think about this, but 3SG support the voluntary sector or the third sector. Not all of the sector, but certainly some of the smaller, more diverse partners. So part of maybe the June presentation is that we could invite the 3SG just to talk about the good work that the third sector does.
Thank you very much, Suzanne. We were just talking about that, so well mind read. Okay, any other questions apart from Kevin, who of course has another question? That was an indication, Kevin, for you to carry on.
Beg your pardon, I thought it was something else. Beg your pardon, thank you. So on the public health update section, please, the first question there was around the health and wellbeing survey. And is this the old shoe survey that was done by the University of Exeter in a different format, or is this a totally different animal?
Yes, that's right. It's the old shoe survey. It's the survey that we've been doing every 2 years for quite a period of time now, and we're doing it for the next 6 or 8 years, funded by St John's for the next chunk of time. There are always some very slight changes. We try to minimise the changes as much as possible so that we are able to get data that we can look at over time, but we do alter things or include new questions at times as needed as the sort of the social context around us changes and behaviour regarding children and young people changes. But yes, it was what was the old School Health Education Unit survey.
Does that, when you say about changes in it, will that include anything around social media and mental health now, as that seems to be a big thing in schools?
Yes, it does have social media and mental health. I don't have the detail on me, but yes, it does include questions because that's such an important change impacting the lives of young people.
Thank you. Sorry, Chair, can I keep going?
Okay, how many more questions have you got?
4.
Oh, gosh. Okay.
Okay.
Make them
and
snappy.
sneaky follow-up on the home dental, if I may, first, which makes 5, sorry. Is the eligibility criteria around the home dental?
Top, if you divide Baines by areas of deprivation, it's the 6 most deprived areas, populations in Baines.
Thank you. Under the whole system health improvement work, who actually is leading that, and what's the timescale and success criteria that's coming out of that?
Led by public health, so it's led by somebody called Annette Luca in the public health team, who's a public health consultant, working very closely with many people across the team and across other teams in the council as well. We're aiming to have something coming back to the Health and Wellbeing Board around July time, June-July time. There's an interim report coming to our next Health and Wellbeing meeting, but something more substantial in June and July time. And it's very much taking and recognising that people's lives and the risk behaviours on people don't act singly. Things are very complex, and risk behaviours and risk activities relating to smoking, tobacco, alcohol, exercise, healthy weight aren't just individual choices, but they're very much determined by the environment in which we live. So it's trying to bring that together and looking at it from a whole system perspective.
And congratulations on the health specialist training location, whatever award. It seemed very special. Does that get any additional funds for us, or
unfortunately,
anything you now have to do?
No, unfortunately not. It would be lovely if it did. Unfortunately not. Every local authority is involved in being a training location for public health registrars, so people who are training to be consultants in public health. So we are a training location, and so we support it in public health and across the organisation as well by working very closely with other colleagues. So we are assessed every year, and this year and for the past few years as well, we've been assessed as excellent, which just wanted to share that because it's a credit to the council as a whole.
Yeah, fantastic. And the last quick question was around food insecurity. Is that part of the Food Equality Action Plan, or is that something additional?
That's right. No, it's the same. It's the same.
So it's part of the plan that is being, and what is it designed to do, the toolkit, or how will it help or benefit?
Yes, it's all part of the same work, and it's some research that's been undertaken, led by Bath University, and it's a toolkit. And apologies, I'm just going to very quickly remind myself, but it's part of the whole food equity work that's been ongoing, and it's a toolkit that should enable local partners to think through how can they address and take action on food security. So it's a sort of top tip, some examples of good practice of ways in which local partners can take action to reduce the burden on local people in tackling food insecurity.
Thank you
We
very
want
much.
to turn the research into something that's very practical for local organisations. Thank you.
Okay, and just, I wasn't aware of this, but when you have asked your questions, if you then turn your microphone off, the camera then will then go to the person answering the question. Otherwise, it just stays on you, Kevin.
Thank you.
Thank you. And Liz?
I just want to ask a question about the provision of minor adaptations. And I know this is a statutory requirement, but it's going back in-house in October 2024. Given the staffing cuts that have been made, are we confident that we, by taking them back in-house, we're going to improve things? And what guarantees do our residents have that this will actually happen? Thank you.
We haven't done all of the scoping yet, so that question of you asking me, am I totally confident? Not yet, not when we've done all of the work. The whole idea behind this, that we have a really good infrastructure in our housing department, and that connection with the housing department and their overview of properties already. We'll be able to have bigger purchasing power as well and a bigger infrastructure across the council, so we'd be able to deliver a much more robust service. So yeah, I'm not expecting it to be part of a savings. I'm expecting to actually put more finances into the adaptations in DFG, because there's a massive pressure. We've seen a growth, but I also think we could be much more efficient if we use AI and we use some of the technological stuff that's coming forward. So yeah, that's the reason why we've done it. And I'm quite looking forward to see what that will look like, because I expect it to be an improved service just because of the size of the council and our ability to be able to deliver a good service.
That's really good news. It's going to be improved and more money is going to be spent on it. Thank you.
Thank you. I just have a couple of questions, some of which have, I think, been slightly touched on. So just going on to food insecurity. I know at our last meeting we had questions around allotments and the encouragement of allotments. Will that be part of the work that you're doing as well, Becky?
It will be considered by the group, but it's not something that's very specifically sits within the remit of public health. But in terms of that wider food provision, good food provision, community engagement, it will be something that's considered by the food equity group. But it's not something that public health leads on.
Thank you. And then the point that was made about addressing the education attainment gap, is that going to also be done with St John's?
So yes, they will work very closely with St John's and are very aware of the projects that St John's are already funding and the schools that they are already supporting. So they're a key collaborator in it. I believe Amy came to the last Scrutiny meeting, didn't she, to talk through the project in more detail.
And then moving on to oral health, I'm concerned, of course, about those schools that have not signed up and those children that will be missed. And in recent weeks, there was a news item about a dental bus. I think that was being run by a charity, not in this area, elsewhere in the country. Is that some sort of initiative that you might want to link up with in order to tackle those, kind of like the dental deserts?
That sort of falls under dental access, dental provision. So I'll hand over to Lucy, if I may, because that sits with the ICB.
Thank you, Becky. So £700,000 has been earmarked for a dental bus for Baines, Swindon and Wiltshire. We're just working through how we operationalise that at the moment, but happy to bring an update back to a future meeting, but it is within our plans.
And then if it's the same model that I think I saw, it will also help adults as well as children.
That's correct. It's an all-age facility, and we're also looking at the opportunity that that bus may bring to reach some of our communities to provide broader than dental access, so that whole concept of making every contact count. So a development plan, a strategic plan is just being worked up, led by Jo Cullen, our Director of Primary Care. And as I said, really happy to bring a further update because the speed around that is quite quick in terms of the money coming through from NHS England.
you. I think we will all be very interested in an update as soon as possible on that. And then my last question is around, and it's not mentioned in the update at all, but it's about the solar panels that I know have been added on to Bath Sports Centre, which obviously I'm very pleased to hear, because obviously that will help address the energy needs of the sports centre. We all know that swimming pools, for example, take a lot of energy to heat. It was a suggestion I brought forward to the in a statement to Cabinet last year, and I just wondered whether or not there is any consideration of doing a similar piece of work for Culver Hay Sports Centre, which remains closed. The second swimming pool does.
Yeah, can I answer that?
You may
because
answer that.
The Culver Hay site yet hasn't been formally approved with regards to the DFE proposals for the free school and the AP provision. And under those circumstances, it needs to go to Cabinet before we can actually decide what's going to happen with regards to the site, plus the temple, plus the swimming pool, plus other housing. But I think the big issue is going to be about the design of the buildings, because I think we will want the buildings to be as effective as we can, and that may not actually then fit into the design criteria of the DFE. So it is something very much up in the air, and I'm more than happy as soon as we get a formal governance arrangement with regards to the site to bring that back here so that we can report more fully on it. But I think it's a really good point, and I think we will certainly be wanting that to happen with regards to that site.
Do you have any idea of the timescales of the formal governance, as this has been going on for, well,
yes, I've got a meeting with local members, I think, probably the week after next, and I've asked us to actually get a proposal going to the Cabinet on the 9th of May, but that has to be fitted in with the proposals, you know, that are going to Cabinet, but that's my request. So I'm hoping that we can actually, after going round and round in circles with regards to this site, actually get something moving forward. And whilst Becky was talking, I was sending emails to try and get that to actually happen, because I think it is important that we actually don't just keep sitting on this. As you know, we've been trying for a long time to get Culver Hay moving forward. And I think it's an exciting opportunity, and we've got to make sure that we actually confirm to the Department for Education that that site can be made available to them.
Thank you very much. You know I'll be watching developments with a keen interest.
I'm well aware of that. Thank you, Chair.
I don't believe there's any further questions on this paper, so I will move on now to the next paper, which is the Integrated Care Board update from Lucy. Obviously, we have seen the update. I don't know if there's anything further you wanted to add. Otherwise, we'll move straight into questions.
Hi, Chair. Happy to move straight to questions.
Thank you, Lucy. Michelle.
Thank you. This isn't part of the report, but I just wanted to share a recent experience I've had with A&E when I took my 17-year-old son who had a suspected broken hand. And we went to A&E first. It was really busy. We live around the corner. It was really busy, so we thought we'd go to the minor injuries unit at Poulton. So we did that. Got there. We were seen really quickly. It was very efficient, but they couldn't X-ray him, so we were sent back to the IUH. The reason why we didn't go to the IUH originally because there was a 7-hour wait. We then ended up kind of being stuck in the 7-hour wait at A&E, which could have been avoided if he'd been able to be X-rayed at Poulton. And it made me think that, and I'm councillor in Newbridge, so I live near the IUH, so I see on a regular basis ambulances queued up outside. And on that particular day, there were 15 ambulances queued up outside. And I spoke to one of the nurses who said that happens every day now, and also that those 15 ambulances are just the ones you can see. It made me think that, you know, Owen, my son, probably wasn't the only person in A&E who probably didn't really need to be there. And my experiences as well, we had a discussion earlier about GP services not necessarily working as well as they should. And also, we used to have a walk-in centre in Bath, which was away from the RUH. I just wonder how much pressure is put on A&E because of the lack of services elsewhere. And my experience was he could have been x-rayed at A&E, he didn't, at Paulton, he didn't have a broken hand. We could have gone home and we wouldn't have added to the pressure in casualties. So I just wondered what work is being done to address that, because we see reports every day on the news about A&E being under extreme pressure, and I just wondered what work is being done in the background to address that.
Thank you for your question. I'm sorry to hear your son Owen had a long wait with yourself. There is a huge amount of work going on around our emergency departments, and the need to be able to segregate what is a true emergency and those individuals that can be safely provided care via an urgent treatment centre. One of the bits of work that was starting last year that was paused over winter that we're just picking back up again is that whole piece around how we look at avoiding preventable attendances and admissions to the emergency department. That includes a review of what can be done in our minor injury units. They are minor injury units, they're not minor illness units, for example, and the opportunity to expand that clinical scope is currently being worked through. Imaging is a really important point, and it's part of a pathway, isn't it, to understand treatment plans. There is imaging available at Porton, but not all the time, and a lot of that is dependent on staffing coverage from the RUH, and then we get ourselves in a vicious circle around where the demand is. Within the emergency department at the RUH, there is a separate urgent treatment centre. It can be accessed in a different way, usually through 111 with booked appointments. And we know we need to do more about publicising that to the public to encourage that usage. And we are obviously very well aware of the challenges around primary care access and the fact people feel they cannot access their primary care, so they attend the emergency department. So the work that we're doing, which is being clinically led, is looking at how we expand the scope of what can be done in minor injury units, including increasing access to radiology and imaging across all our units, just not that at Poulton. Because for some people in Bath, for example, it might be quicker for them to get to Chippenham or Trowbridge. So it's across the piece what that offer looks like. I also wanted to reply that there are times, sadly, when there are 15 ambulances queuing outside the IUH, but those times have quite significantly reduced in the last 4 to 6 weeks. And that's part of all the work we've been doing with our ambulance colleagues and our community partners to look at when people call an ambulance, do they actually need a 999 response? And can we direct that activity in a different way to services like our virtual ward, for example? So the work that we're planning to do in partnership with the RUH is to bring primary care, clinicians from the emergency department and the urgent treatment centre, and our community clinicians together to look at what does that offer need to be for the future. The first conversation is happening within the RUH footprint next week, actually, and then we're expanding it over the next few months to really get a plan together for next winter. So as I said, I'm sorry Owen and yourself had such a difficult and a long wait, and it's really getting under the skin of those clinical pathways and directing people to the right support at the right time.
Thank you for that. And the biggest problem for him was that he was just really hungry, so he was moaning the whole time. But I just wanted to say, actually, you were saying about the urgent care centre in the IUH. We did actually ring 111 and we were sent to Poulton. At no point did they mention the urgent care centre, and it's actually not very well signposted. And I think the risk is having it there is that people will just go to A&E because they think that they'll just be sent there and then they kind of get stuck in A&E.
Yeah, it's a really good point, isn't it? And there's been two trains of thoughts around urgent treatment centres. We did have Riverside, and there was a national drive for co-location with emergency departments. So the NHS co-located urgent care and emergency departments, and we're going back round that circle again. The urgent treatment centre could be better signposted at the IUH, and we have picked that up. Also at times, and without wanting to get too technical, the way 111 works is we use something called a directory of services, which gives the team in 111 a menu of where you can, it's an awful word, dispose the patients to. Bear with me, that's the word we use, unfortunately, in health. What happens sometimes is if the emergency department is very busy, it turns red on that directory of services and therefore isn't an offer. What we have seen is an increase in patients from the Bristol footprint, for example, where they don't see that it's red on the directory of services, so keep attending. So we're doing some work to better understand that directory of services and promote the right location for the patient. The urgent treatment centre now is a separate stream to the emergency department. The reason we've done that is that hopefully that you will see a quicker flow through the urgent treatment centre pathway rather than just being in the flow for the major department of the emergency department. But we recognise we need to do some more work. So your feedback's really helpful to help build that picture. So thank you.
Come back again. Would it be possible to have updates on that to the panel? Because I think that's a really key thing, and it's something that a lot of our residents talk to us about as well.
Yeah, we'd be delighted to bring something back, particularly on our work around that prevention of avoidable admissions and attendances to the emergency department. Delighted to do that, Chair.
Thank you. And I think an important part of that will be how you're publicising, you know, what residents ought to be doing, because I think it is a little bit of a mystery quite often. So I'm going to pass to Leslie and then Ruth.
Thank you. I wanted to ask about the community health contract. This is becoming quite imminent now, so can you tell us who is in the frame for this? Bearing in mind that the public opinions seem to be that we don't want to see the contract go to yet another private equity company, so are you looking at a cooperative type model? And also, how will you be consulting the public on this? Thank you.
So I'm sure the panel may be aware that we are in a live procurement process, so I'm unable to make any comments at this stage.
Apparently Paul May, though, might be able to.
No, Chair, can I give a standard reference to the fact that I'm a non-executive director on the board of Sirona. And I've no idea whether Sirona are applying or not, but I think it's important that I actually register that point now. Thank you, Chair. And if it goes any further, this discussion, I'll leave.
Thank you. I don't know if you had an additional question.
Can I just come back on that, Chair? So surely you can tell us how you're going to consult the public?
Unfortunately, as we're in a live procurement, I can't make any comment about that contractual process.
Presumably you could agree that there would be some element of public consultation?
I'm really sorry, but as we're in a live procurement, I can't make any comment.
Okay, Leslie, do you have some other questions?
Chair, I don't think that's an acceptable answer. Can you ask for a bit more detailed explanation by that? I mean, Leslie asked a very general question about the principles of it, and the answer is not even giving any response at all to Leslie's question. I think Leslie's question was fair, and I think it can be answered in the form of principles without going into the detail of the consultation.
Can you do that?
I can probably say that there is a principle that we will work with the public, but that's probably as far as I can go, I'm afraid, because it's imminent. It's in the middle of the contractual procurement process, so we are very governed by what we can and cannot share, I'm afraid.
Perhaps it might be possible to have a conversation with Laura, and if there is maybe any additional information that can be circulated to this panel, perhaps that could be forthcoming.
I'm very happy to take that back as a question and bring back anything that people feel is appropriate to share at this time. There will be a period when we will be able to share more, but it's just not at this particular period in a contractual position.
And then just adding to that then, when would you be able to? Just a sense of time frame.
A sense of time frames. I believe we may be in a position to share more potentially July, August time, but that will be dependent on the procurement milestones. I'd also like to add that in terms of feedback on our community provision at present, we obviously engage with the public at this on a regular basis in terms of getting feedback on the community provision as it is. So I just wanted to share that with the panel.
Thank you, Lucy. Suzanne.
I just wanted to add that the time frame that we're working through, because I sit on the ICBC, which is a massive big term for just overseeing the procurement. We would hope that we will have a preferred bidder by September. The plan that I've discussed with Laura is that at some stage when we're finished the procurement and the final bidder or the final provider is identified, that we would come here to scrutiny, and that's what I've agreed with Laura. Before that, we really can't do anything because of the live procurement, and I'm terrified to say anything in case I incriminate myself some way legally, but that is the process. So at least the panel's got an understanding of September. We should be here with whoever is the preferred bidders or whatever, and who's been successful. You would be able to review the process, I guess, and see this process. It's not the council's procurement, it's the ICB's procurement. Therefore, we, as a council, will not be taking responsibility for that. But we will come back here, and that's the agreement. So I'll need to speak with you, Chair, and Laura will as well, about the time frame around that.
So would it be possible to have the specifications for that new service once it's been agreed?
Once it's been procured, we can share the specifications. We can't share before that. And for July and August, what we could bring is an update on the process, where we've got to with the process.
Okay, Leslie.
So can I ask then, you just said that you go to the public on the provision of the service, so how will you make sure that that's accessible and the public can get the opportunity to comment on the services?
So the comment I made was around the services we currently have, where we regularly receive feedback, and we use that feedback as part of any procurement process.
Are you happy with that answer, Leslie? Did you have a further question?
Well, it just sort of concerns me a little that what seems to be happening is this contract is going to go out. I'm not convinced that there is any comment from the public on the actual contract. It's just been stated you do go back to the public for feedback on the provision. Presumably that's a questionnaire. How else is it done? How else do people get an opportunity to have a discussion on it? Because it's one thing filling in a questionnaire, but it's another thing having a question and answer session where obviously things come up in that discussion.
So my comment wasn't around the procurement at all. My comment was around how we receive feedback. And in answer to the question, we do things like friends and family. There are questionnaires. There's also individual discussions with patients and families who currently receive services for the current provision.
Thank you. So does Healthwatch have a input into this?
I can't discuss the live procurement in terms of who's involved in the process. I'm sure that's a question that could be brought back if you wanted to ask that exact question. In terms of Healthwatch, they do have a role in the current provision and any reviews that take place, as they would with any other commission service.
Thank you. Leslie, any further questions from you?
On a different issue, around the group model for hospitals, where are we in the area around that provider collaboration?
Could you give me a little more detail around what you mean for group hospitals? Sorry.
Well, I understand that nationally that hospitals are being expected to group together and share their ideas around services and service provision, planning together, transforming services.
In Bain, Swindon and Wiltshire ICB, we have something called the Acute Hospital Alliance. The Acute Hospital Alliance is a formal entity that consists of the Royal United in Bath, Great Western in Swindon and Salisbury Foundation Trust in Salisbury. They work together on a range of issues ranging from clinical pathways to back office savings. So within that remit, we do have a vehicle for supporting our acute providers to work as a group rather than working as individual organisations.
thank you, Lucy, and thank you, Leslie, for your questions. I think Liz actually wanted to ask some questions on the back of what Leslie had said, so then I'll come to you, Ruth.
Thank you, Tina. Really, it relates indirectly to what's being discussed at the moment, and it's about GP practices in the sense that primary care really seems to have broken down in many areas. You cannot get a GP appointment. Therefore, the huge strain on accident and emergency is growing. I mean, I'm very proud of our minor injuries unit in Poulton. I'm the ward counsellor, and you do get x-rays there, but apparently maybe on this day they weren't available. It is an excellent place of being able to be seen by professionals when you can't get a GP appointment. There are pressure points at various times during the week where you cannot get an appointment, even an emergency appointment, and I think this is not just in 1 or 2 surgeries, but it's replicated across our area, and I think it's something urgently that we need to look at. So although it's indirectly to do with the agenda that's about 2 GP practices merging, I do think we need an update on what is happening and what can be done to improve the situation. Because if you cannot be seen, I mean, residents have contacted me to say awful things have happened. People have ended up in emergency situations in hospital where they've nearly died because they weren't able to get a GP appointment. So I think this is something, I mean, obviously the GP practice didn't realise, but things get out of hand very quickly. People get unwell very quickly. And if you cannot see a GP, within a reasonable time period, well, the whole situation really needs to be looked at. So maybe you can answer something now, but maybe this needs to come back at our next meeting. Okay, thank you.
Thank you for your question. I'd be delighted to bring something back. There is a huge amount of work, a whole strategic programme of work around primary care access and how that can be improved. So very keen to bring a report back to the next meeting through our Director of Primary Care. That work, just to give you a flavour, includes a better process for triaging individuals when they ring the GP, because a number of individuals are actually better seen by a pharmacist, a mental health professional, rather than the GP themselves. So we can bring back that whole plan. I just wanted to add, I'm a patient of Bath Eastern Medical Centre. They provide amazing same-day access. So I think it is a mixed bag across the piece. And one of the things that we really need to look at is consistency.
A supplementary question. I mean, the problem with consistency is that maybe certain practices are better endowed than others, that the population within a certain practice may be too big for the actual practice and they're not able to cope. But the other very concerning thing is, and this is what we discussed in our pre-meeting, is that let's say a patient has got a problem, sees a GP, the GP says, get back to me within so many days. If nothing happens, you try and get back. It's not just, it seems to be happening fairly consistently across our area. So you try and get back to your GP, but you have gatekeepers, the receptionists, which rightly decide whether or not you can actually access the doctor or not. And we were wondering, I think it was raised, could there be some code that the GPs asked you to get back to them? Because if you can't get back to them, if the painkillers haven't worked, if the treatment hasn't worked, if they can't get back and see or speak to their GP, things escalate and people end up in hospital. So I think that's another area that we need to look at. And hopefully you'll be able to feed us back on what can be improved.
Yeah, very happy to take that question away as part of the primary care access. Again, just giving a personal example and appreciating not everyone is digitally abled. Our GP practice use text messaging and other forms of communication and technology, so you can go straight back to the GP. But let's bring that back as a whole presentation, because there's a lot of work, and it might be interesting to also look at whether one of our GP leaders would be able to come and talk to it, because to hear from a GP themselves might be really helpful for members of the panel.
Thank you. Paul, was it on this point?
Point, can I just also make the point about we're starting a local plan process which could see an increase of something like anywhere between 10 and 16,000 houses in the area, and I've been making contact as chairman of the Health and Wellbeing Board with Laura to make sure that we're actually thinking about the impact on GP practices, because I've had comments made by GPs in the area that they can't take additional numbers of houses in particular areas. So it's something I think we've got to be very mindful of, that there are things that the council are doing that can actually make those problems that you've identified, Councillor Hardman, as even worse. So I think it is something we've got to be thinking about.
Thank you, Paul. And obviously, if anybody wants to contribute to that local plan, when's the closing date?
Tomorrow.
Tomorrow. So you need to get onto it quickly. Ruth, and then Leslie, and then Joe.
Thank you. Yeah, I was just going to add something to the what Michelle and Liz had said previously about ambulances, number of ambulances and so on. One of my neighbours recently was telling me that her husband was very poorly, and they tried to get a GP to come and to make a home visit because he was too poorly to go to the surgery, and but there was no GP available. I don't know which surgery it was, but it's in Bath anyway. And so in the end, an ambulance came. As it turned out, sadly, he actually did need the ambulance and he went to hospital. But I've just wondered, does that happen often, as far as you know, that you know, people will have to resort to calling an ambulance because they're not able to get a home visit, and they're not able to, you know, somebody really is poorly and they can't transport them to the A&E. How often does that happen? Is there any data about that? And yeah, that whole, as you say, how the primary care sort of fits in then with A&E, and what you can do to improve primary, or what can be done to improve primary care services so that that kind of thing doesn't happen, because it's obviously really very costly, isn't it, to and adds to the pressure on the A&E department.
Thank you for your question. I'm sorry to hear that someone was so unwell that they needed an ambulance. I wanted to raise that there are different ways now we're approaching how we care for people at home. GP home visits are quite a historic model of care, and what we've moved into nationally and locally is something called the virtual ward. So within the Baines footprint, we have a virtual ward run by HCRG in the community. That's when multi-agency professionals go into the home prior to an ambulance being called to assess the patient and provide care to keep them at home. So very happy to take away a question about, do we have any data about home visits not being available? But we're working with primary care so that if they don't have capacity, who is an alternative clinician, but importantly, there are now different pathways when a GP might not actually be the best person to assess the patient, and that the virtual wards have direct links into that hospital team to provide hospital level care at home. So very happy to provide any more information about the virtual ward, which is the direction of travel we're moving in, to provide that acute care in the community, which is a different offer to a GP home visit.
Talking about virtual care, that does still mean that an actual person goes to the home.
Yeah, you can have a doctor, you can have a paramedic, or you can have a enhanced care practitioner nurse go and visit you in your own home. And those individuals can do things like administer oxygen, IV medication, intravenous medication at home to avoid that hospital attendance. So that's the change we're seeing. It's not so weighted towards GP home visits. It's about a multi-agency team physically going to see the patient, and then they're monitored as what we call the virtual ward.
Thank you, Lucy. And thank you, Ruth. Next, I have Leslie and then Joe.
Yes, I welcome the report to come back regarding the triage system. Can you include in that the repeat prescription issue? Because talking to residents, they're saying it's a bit like the gasman cometh, that you fill in a form on one day, you go round the system, and you end up on another day still having to fill in another form. The system that they've been using, you try to go into it, but you have to log in, and if you haven't got login details, you have to go to the surgery. You can't do that on the triage form. You have to ring the surgery, One person spent 25 minutes trying to get through to the surgery just to ask for a repeat prescription. When they said yes, they put it through, they then got another text to say, no, they've got to fill the form in because it couldn't be on a repeat prescription, you know, round and round and round. So could we have a look at that? And also then that links in with community pharmacists, which seem to be disappearing fast as well. So in Radstock, what we've got now is a chemist that doesn't open on a Saturday. So if you can't get there between 8 and 6 during the day, then you can't pick your prescription up locally either.
Thank you. And again, I'm sorry your case spent a lot of time trying to talk to the GP practice. The direction of travel around repeat medications, and again, noting that not everyone is digitally abled, is around the NHS app. The NHS app is actually easy to use. You can request your repeat prescriptions, and you do get a note if you need to talk to a clinician before your repeat prescription is issued. So I believe there is some more work we can do to support people to access their healthcare. That includes their GP record through the NHS app. I can certainly bring back a report around repeat prescriptions, and I can feed back into the primary care team that concerns have been raised. But there is a lot of work going on about repeat prescriptions. A number of people end up in the emergency department because of repeat prescriptions, so we do encourage people to check when their medication runs out, and I'm sure we can do more about communicating the routes that you can avoid those last minutes where you don't have any medication left. In terms of community pharmacists, I know we have public health colleagues in the room. That's a question I know that's been raised before around access to community pharmacy, and it's being picked up by the health and wellbeing agenda.
Thank you, Lucy. Okay, I've got quite a list still. So Joanna, Kevin, Paul, and then if nobody asks my questions, I'll ask my own questions. Joanna.
Hi, thank you. So just to follow on from Councillor Doherty on the primary care practice and how people access things. I too, as a parent, have had a serious situation with a son. And what I found interesting was that, I mean, he had a serious surgery and was told that he had to have follow-up care, and that we would then to go to our local doctor to get that sorted out. Getting the gatekeeping to get to that was impossible. And the fact that when we got there, we were then told we had to drive an hour to Polton every day, there and back, when his notes clearly said he shouldn't even sit down. You also then find people are very vulnerable when they're unwell, and also of different ages. So he was a young person. He didn't understand. So when he went on his own, he did not know how to get the right information and the right support that he needed every day for 3 weeks. And there was an endless battle to the extent that I had to go up and sort all of that out for them. Now, that's not reasonable, because there are lots of people who are not well who shouldn't have to have somebody else advocate to make sure they get the right health service. And if he hadn't have had somebody to do that, he would have got sicker again. So I guess my question is really, with the report that you're saying that's going to come back to us on primary care practice, is that there is a real need to understand the gatekeeping and the information that's been sent to people when they've actually been discharged about their follow-up care that isn't properly delivered. And further, from what I can hear in the room, and there aren't actually that many of us, we've all seemed to got a story, and following to the further report that we had coming, what I noticed was that that had an ethnography on it. Is there a need, actually, to look at the actual stories that are going on, because they are endless, and how do we assess them rather than in a quantitative manner, but in a qualitative manner of there are lots of people sharing these stories over and over again, and we just go round and round in circles.
And again, I'm sorry your son had such a difficult time. Obviously, I can't comment on the individual case. I'd be happy to have a conversation with you separately. What I would say is anyone having elective or emergency surgery should be have access to something we call a PIFU, which is a patient-initiated follow-up, which means they don't need to go through the GP. They can go back to where they had their surgery if they've got any questions. So if your son wasn't offered a PIFU, that's something I'm very happy to have a conversation with you about, because we're trying to commission care in a different way. Not everything needs to go.
It wasn't that. He actually had to have a wound cared for every day through a nurse, and he was told to go to his local practice to do that. And they said they weren't going to provide it for him, that he had to make a journey of an hour every day to a different place. And he was told not to even sit down. So how do you get there? We were prepared to walk the 10 minutes to the local surgery, but that was told was not on offer.
Yeah, so very happy to have a separate conversation about your son's case, but wound care is obviously something that we would need to pick up. I'm very happy to bring back a report around primary care access, as you've described. In terms of your questions about case studies, we do use case studies all the time in the NHS for learning, but I will ask them to include how they do that within primary care as part of the report.
Thank you, Lucy, and thank you, Joanna. Kevin, and then Paul, and I've drawn a line under me.
Thank you, Chair. Yeah, just coming back on the triaging reports that you're very kindly going to let
Lucy,
us have.
do you want to turn your microphone off?
It's
Otherwise
probably,
the
am I not quite close enough? Sorry.
Nothing you're doing wrong this time,
Oh,
Kevin.
okay. Thank you. It makes a change. Yes, come back onto the triage aspect of things. When does the level of knowledge and skill and contact of a triage person become a doctor who is going to be taken off anyway? So from the pure point of view of mental health and patient well-being and the communication of their needs, to actually be able to talk to somebody face to face, to try and explain and also get the person with the knowledge to coax out of the person what is actually wrong. Because I may say I've got a headache and the person may say, well, yeah, but do you also have a pain here or do you also have this or whatever? It becomes the triaging element. When I was in school, it was always the most experienced person that had to be the triage person for a particular aspect of SEND or whatever, because they could ask the questions and have the knowledge. My concern is that we're getting down to a point to try and save the person at the top some time or whatever, that we are now becoming lots of points of contact without necessarily getting to the heart of the matter or to the support of the person that needs it. And that you will still need the expertise of somebody who has an awful lot of knowledge and could almost be the GP to actually make that first point of contact with you.
So, Chair, I could spend an hour talking about clinical triage because it's a multifactorial pathway and at different levels of care, different people provide triage. Within the primary access report that we're bringing back, I will ask them to give you the examples of what some of our GP practices are doing, which is where the GPs do the triage as part of a model. So as a senior clinical decision maker, they are the single point of contact where they will then assess where the patient can best be seen. That's a new piece of work that some practices within the Baines footprint have actually trialled nationally. So if we include that in the report, that may be very interesting. If you take other areas, for example, like mental health, actually, sometimes the best person to do the triage is the mental health professional with that expertise, not a consultant psychiatrist. And again, if you're doing triage around broken limbs, you don't need to be a consultant orthopaedic surgeon, you could be a radiologist expert. So it is multifactorial across the pathway. But for this particular conversation about primary care, let's put in that report some of the pilot work they're doing around GP-led triage with the use of digital technology to support that. There's a great presentation from one of the GPs. I'd love you to hear it. It's really, really interesting.
Chair, can I
yes,
just
you may.
A couple of quick ones. Thank you. Well done on the maternity services and the outstanding bit, the excellence bit there. Is the medical services now at the RUH away from RI? Because that was initially being worked on and I haven't had an update really.
So there was a broader CQC inspection within the IUH that was subject to an action plan. If I may, Chair, I will get an update for you around the broader range of services and respond separately to that, if I may.
Thank you.
Thank you.
The other bit I've been trying to tease out, and it's, I hope it's not me, but it could very well be, is the responsibilities that the person, the SEND representative has on the ICB. And again, in the answer that was given, the written answer, I still don't understand the duties and obligations that the ICB have around SEND. Now, SEND to me, in a school capacity, and looking at special educational needs and disabilities within school, and how is that being supported somehow that I don't know about by the ICB, and how are they supporting into, additional funding, additional resources, or are they connecting certain things together? We just need to get a handle on this ICB SEND rep on what they're actually doing. And just as a subsequent point to that, which you might want to say, is there's supposed to be a DFE change programme partnership for SEND, which some ICBs are involved in. Is ours involved in that? And if it is, we'd love to know some more information about that as well.
Thank you. I will take back for further information. It is our chief nurse who is the SEND executive lead for the ICB, but I will ask for further detail around what that encompasses in terms of roles and responsibilities. I don't know the answer to the DFE change programme, but I will find it out for you. There is a lot of work going on around the SEND agenda. For example, there's the National PINS programme, which is around neurodiversity support for schools. Baines are involved in that, with a total of 40 schools across Baines, Swindon and Wiltshire being involved. Very happy to give a future update on that PINS update, just to give you one example of the tangible things that are happening around the SEND agenda at this point in time.
Fabulous, good, I look forward to that. And the final question was just around, and again, a written back question around the pharmacies bit. There was nothing on, a lot of reports recently about pharmacies unable to cope, can't get staff, and again, they're being put upon by a system that says maybe you can do all this and actually they can't. So again, have you had reports or updates on how pharmacies are coping with their particular staffing of this new initiative?
So up until very recently, pharmacy commissioning was the responsibility of NHS England. It's now moved to integrated care boards, along with dentistry and optometry. We're just in the process as of an ICB of developing a pharmacy strategy as part of the transition. And again, I'm very happy to take a question back to provide more detail for a future discussion around that pharmacy question, but that we're just in that transition phase about becoming responsible for that area.
Thank you, Lucy. Yes, one of my questions was around the capacity of pharmacists to do all that was expected of them, especially when you're usually just one pharmacist in a practice. Paul.
Thank you very much, Chair. I'd just like to add just a general comment. I'm a regular user of the NHS app, which I had on my computer at home. And, following on from Leslie's comment, I just downloaded it in less than 2 minutes onto my phone here. And it's very useful, it's very easy, and it saves everyone a lot of inconvenience and help. And so I would urge everyone to get the NHS app on their mobile phone. I know everyone isn't digitally connected, but a very large percentage of the population have a mobile phone. And a large percentage of those nowadays are smart mobile phones. So the more people are onto this way, the more effort we save GPs from redundant questions, and people can service themselves, and it's very efficient.
Thank you, Councillor, for that feedback.
Thank you very much, Paul. So, as I said, I'm going to be the last person with questions on this item, and I think that one of the pieces that's been missing is around the demographics of our population, particularly students. So we now have a population that in Bath includes 25,000 students. That must put a huge pressure on the numbers of on our GP surgeries, because they have not increased in numbers to the same degree. I know there's a big problem for students because they can't be dual registered. They have to either be registered where they study or at home, and that in then turn puts pressure on emergency services if they need any sort of help or access to medical services in the place where they're studying. It's a question that I've asked before, but yet never seems to be resolved, and I suspect part of this is a national question, and it would be very helpful to know that that question is being asked of the right person at government level.
Thank you, Chair. And again, I'm very happy to take some information just to give you some form of update. I recently met with the GP lead for the University of Bath practice, and we're doing some particular work with that practice around the high level of students at the University of Bath who have an autism diagnosis, and how we can particularly support a safe transition between GP practices, particularly those with ASD and ADHD who are on medication. So that's a particular line of work we're doing at the minute. Also, absolutely noting your concerns around capacity, the GP practice in question brilliantly responded to a recent meningitis outbreak at the university. So we do a lot of work with that practice, but I'm very happy to take the question back around broader increase in students and making sure there is sufficient primary care provision.
Thank you. And then another question, which is, I think, about possibly capacity. And it might be that I have heard this particular issue incorrectly, but I believe that there is a drive for, if you're going to visit your GP, for you to go with one symptom, one problem, and not a range of problems, which obviously then means you have to make multiple appointments. And as I think maybe Kevin was suggesting, sometimes your condition actually, or the symptom that you present with, if you were able to bring in all the other ones, might give a better picture to the GP. I just wondered, A, am I right in what I've heard or think I've heard, and B, how is that going to be addressed?
So I would want to ask a GP that question, so I will do and include the information in the primary care access report. I think there's a whole suite of things we can bring together, and something about what are the plans for that initial consultation, including the triage process, so we can be really clear on it.
And this is the very last question, and it's about the police and the role that they have. Often they're the first ones on the scene of a mental health crisis, and are they being incorporated into that integrated care board's work?
They are indeed. So within Baines, Swindon and Wiltshire ICB footprint, we have 2 police forces. Within Baines, we work very closely with Avon and Somerset Police. There's a whole national drive which is linked to how police respond to mental health incidents, and we are working in collaboration with both police forces. We speak regularly to our police colleagues, and we regularly hold MDTs, so multidisciplinary meetings, including police officers around individuals. So just to assure you, there is a lot of collaborative working as we see the national agenda increase around policing and mental health crises.
Thank you very much, Lucy. And yes, on that last question, I think your time here is, you're almost free to go unless you want to stay. Okay, thank you. Okay, we're now moving on to the next item, which is COVID-19 care home study. Alison, I don't know if you want to introduce this, and then I'll move on to Paul and to his very patient colleagues as well.
Yeah, this report came about because there was some information that came out during COVID which seemed to suggest that in Bath and North East Somerset there'd been a higher than expected proportion of people with COVID who were dying in care homes. And obviously that had raised some concerns about practice. Some of you who were on the previous health scrutiny panel will remember that I think it was last March we brought an interim report to panel which looked at the wider data on that, and what that told us was that although there were a higher number of people in Baines dying in care homes, there was a very low number of people dying in hospital, and also the overall numbers of people dying of COVID in Bath and North East Somerset were comparatively low. So that allayed concerns to some extent that this wasn't, that we had very high numbers of people dying of COVID, unexpectedly high in general. Also, what that showed was that looking back at the figures over preceding years, that actually that was a pattern that had been in place in Bath and North East Somerset for some time. And that was down to work that had been done on advanced directives, so talking to people who were nearing the end of their life and talking to them about how they would like their care to be at that point. And an awful lot of people do say they would prefer to die in their normal place of, in the place where they live, with people who they know looking after them. So for that reason, I think there has been additional support put into care homes by primary care to enable that to take place. So that was the background to it. But in addition to that, a decision was taken that we would commission an independent piece of work to look at qualitative data on that. And what that was going to do was to talk to people who had been in the care homes during that time to understand their experience of what it was like. And that's, we've got our colleagues from ARC West here today who undertook that research and who will be able to provide a lot more detail on that. But certainly having read it, I think, I mean, it didn't come up with any particular surprises, and it didn't raise particular concerns for me, but it did give a real insight into just how difficult it was, I think, working in care homes at that time, how challenging it was. And I think, given that, you know, the chances are there will be future pandemics, I think it's really important that we learn from those experiences in terms of planning for the future. So I'm going to hand over to Paul and the colleagues from ARC West now, who can, I don't know if you want to do an introduction, got a presentation, or if you're just going to take questions.
So thanks very much, Councillor Bourne. So yeah, just to say again, just to clarify, as Councillor Bourne said, that previous analysis was shared last year. So just to clarify, that work is all at the level of the local authority, so it compares Baines as a whole to anywhere else, to Swindon, Oxford, Middlesbrough, Brighton. And it looked at trying to understand how our experience was different to anywhere else. So what these two new studies bring, one of them is looking at analysis of data, but across all the care homes within Baines, and looking at any possible risk factors, so we'll talk in more detail about that. And the other, as was said, was interviews with staff from those to understand their experiences. So these two studies are more focused on within Baines, and that previous one compared Baines with everywhere else. So I will hand over, and I'm going to put some slides on the screen, and then we'll have hopefully plenty of time for questions afterwards as well. Whoops. Did that just... I don't think that's shared right onto the chair.
Because I need to look at the slides. Yeah.
Who's going to go first?
Yeah, I'm going to go first.
I'll just go into slide view. Could you just use it?
Yeah. Okay, so thank you very much for having us here today. I am Teresa Redaniel, and I'm a senior lecturer in health services research and epidemiology in ARC West. So this presentation is divided into several parts. So the first one is we'd like to give you an introduction of who we are and what do we do. And then the next one would be about the methodology that we use to investigate this research question. And then we'll be presenting the quantitative and the qualitative results. And then we'll go into the summary and then discussions and questions. So who are we in the NIHR ARC West? So we are funded by the National Institute for Health and Care Research, which is the nation's largest funder for health and care research in the UK. So we support applied health and care research. So what does that mean? We don't go into the lab. We don't do, don lab counts and just do research in the laboratory. We actually do research with a lot of different stakeholders. We look at research that has implications with what's going on with the health and care system. We work with clinicians in the NHS, clinicians in primary care, as well as different stakeholders such as local authorities and the integrated care boards. So we are part of one of the 15 ARCs across England, and it is part of the 135 million investment by the NHR over 5 years to actually make sure that the research that we do is actually going to be have any benefit with regards to the health and care system. So, as I mentioned, we collaborate with local partners, including providers of the NHS, care services commissioners, local authorities. Our quest is actually, we are with 4 universities, so that's universities of Bristol, West of England, Bath, and Gloucestershire. We also work with different charities, such as Mind and Second Step in Bristol, among others. And we work together to conduct applied health research. So the research we do is done in collaboration with partners, and this is how we came down to doing this piece of work. So we work with Paul with Bath Mind to evaluate breathing space, which is implemented here in Bath. So that came about when we were discussing about what else we can do, and we came up with, Paul came to us asking, so we have this thing about COVID in care homes, and maybe you can help us with this. So we've had a discussion, and we came up with this research. So what have we looked into? So we know that there's a massive impact of COVID in care homes. So the cases are 13 times higher in care homes than in the community. They involve vulnerable populations who are at higher risk of death and high number of deaths in care homes. As Paul mentioned, there are higher death rates in care homes in Bains in comparison to similar areas, and when we've discussed about looking more into this and the reasons why. So the research aims that we have for this piece of work is to determine why Bains appear to have higher death rates from COVID in care homes compared to other locations, and whether there are specific risk factors associated with COVID-19 infections and deaths in care homes within Bains. And we also would like to examine what learning from the first and second wave of the pandemic can be used to improve policy and practice. So how did we do this? So we've done a combination of mixed methods. So we have a quantitative and qualitative research. So for the quantitative research, so we've combined different data sets from the Commissioner for Care Homes, the Infection Prevention and Control Team, among others. Also data from UK HSA about COVID deaths and infections. And we've also looked at care home size, care home type, care home ownership, engagement with Bains Council, plus 8 others that I would enumerate later. And we looked at care home level data. So this is not individual patient level data. This is data at the level of the care homes. So we have summaries of those information at the level of the care homes. And we look at associations between risk factors and infections and death. So, but we know that associations do not exactly explain why and how things happen. So we complemented this with a qualitative study. So for the qualitative study, we've done semi-structured interviews with care home staff. So, and this is all about their experiences and perceptions about what happened in care homes during the pandemic. This is not an audit of policy or practice by local authorities or other agencies regards to care homes. So it's basically giving them a voice of what happened to them during the pandemic. So we sample different care homes of different sizes and types. However, we have a lot of difficulty recruiting the care homes. I'll elaborate on that later. So participants and data are fully anonymized in the reports. You have a copy of the report, I believe. And like I said, this is documenting experience to learn rather than audit of practice. So the challenges we encountered with this is the data quantity. So we have data from all of the care homes in Bains, but it's relatively a small number. So we only have 33 care homes. So the data only covered a limited period of time from September 2020 to February 2021. And there are no data from comparator areas. So the reason for this is because we ask for detailed information, particularly about, care homes, what type they are, what is the organization of the care homes, the profile of the patients in there, and the COVID infections and deaths, and we don't have any comparator data up to that level. So most, as Paul said, most of the other data that is available are at a level of the local authority, and we cannot just limit our analysis on the, if we want to really delve into those details, those granular details, we cannot really limit our analysis to local authority level data. So also with regards to data quality, so like I said, only data at care home level is available. We don't have any information governance underpinning the study to actually get patient level data. And aside from that, we don't have data on certain variables such as actual number of residents in the care homes, vaccination status of the staff, staff infection rates, and whether staff work across the different sites. For the qualitative interviews, so as I mentioned, we had difficulties with care home recruitment. So, so we did the study in 2021 and 2022. And during that time, we were just coming out of COVID. There were staff shortages in care homes, so research is not prioritized. They all have to prioritize giving care to people. Also, aside from that, there have been a lot of staff changes. So the managers and staff in post during the pandemic, a lot of them have moved on, and we cannot ask them about their experiences within those particular care homes. So we've had a change of the study design. Initially, we were thinking of just looking at experiences of care homes within Baines, but we had to recruit outside of Baines. So although the information that we've received in Baines are interesting and valuable, but we wanted more granular and more informative data that spoke to issues within and beyond Baines. And we can only do that by expanding our recruitment outside. So as we mentioned, so the data informs and reflect on management of COVID in care homes in general. So what did we find out? So as I mentioned, we have 33 care homes included in the analysis. Most of them are medium-sized care homes, meaning there are 30 to 59 beds, quarter around less than 30 beds, and around 18% are 60 or plus. So we have a total of 290 COVID-19 cases. So the average, we have less than one case per week on average. Average age of those COVID cases is 85 years, and most of them are female. So in terms of death, we have 101 COVID-related deaths during the period. There's also less than one weekly death on average. Average age was 89 years, and still most of them are female. So in terms of COVID cases, we found that medium and large care homes are at greater risk. Particularly, we hypothesize this because there's a lot more population that is available for the infection to go through. There's something that we found in the qualitative study about this, which John would expand later on. We also found that managers in post for less than a year were associated with fewer cases, but the data that we have is not robust enough to actually put more emphasis on this, unfortunately. So the following variables were not associated with the number of cases. So we've also looked at the type of care home specialty, care home ownership, whether the care home had discharged to access beds, whether care homes, what are the engagement of the care homes with the Baines Council during the pandemic, how regularly they complete the capacity tracker, staff turnover, GP involvement, whether LFTs were received and used, and if the staff stayed in shared accommodation. So we didn't find any associations of this with the number of cases. At the same time, so having an outbreak of two or more cases, having an outbreak which is defined as having 2 or more cases in a week in the home is associated with more deaths. And the same thing, having a manager in post less than a year was associated with fewer deaths. So for this analysis, we have fewer care homes because we didn't have any information on 3 of those care homes. So I'll pass on now to John to discuss the qualitative results. Yep.
Hi, thanks, Teresa. Hello, everyone. I'm John Banks. I'm a Senior Research Fellow in Qualitative Research, also at ArcWest and University of Bristol. And I came on board to do this work, I think, sort of midway or as the quantitative work was coming to an end, just to give a bit more detail on it. As Teresa's flagged up, there were issues with recruitment and we did struggle. Just to give a bit of a backstory to that, I don't think there was kind of opposition to getting involved. It was just the lack of time and the lack of prioritisation that people felt toward research. We did a number of things to try and recruit people, including attending the Care Managers Forum and other measures to try and get people involved. And we did have some take-up, but we made the decision to go beyond because we've got such interesting data from the interviews we did within Baines that we thought it was just worth looking at the experiences beyond the boundaries just to get a general picture and just to see whether those things in Baines were the same perceptions outside as well. And I'm pleased we did that because I think overall we've got a good body of data to work with. So we recruited 5 care homes, and within those we did 14 interviews, and they were mainly with managers and support staff. The data were analysed thematically, which basically means we transcribed all the data, anonymised them, and then looked for patterns of responses and common patterns of responses across the data so that it reflected kind of shared experience. So in the report that we've submitted, there are a number of themes that we developed from those from our interviews. And I'm not going to talk to all of the themes here, they're in the report, but I'll just focus on some of the key issues that came up for people who were in the care homes at that time, around infection prevention and control, their experiences with guidance and legislation, their relationships with outside bodies like the wider healthcare system and the local authority. A key issue is the kind of welfare of people, what I've termed the psychosocial aspects of lockdown. So for residents and how they experienced the lockdowns and the isolation policies and the effect on the care homes in general, but also for members of staff as well. And the last point I'll make is around the kind of reorientation of practice. So care homes started doing things a bit differently, which have then carried on into future work modes. Just a final note, and I know Teresa's commented on this already, but the data we represent are kind of participants' views and experiences and shouldn't be read as a kind of checklist or checkpoint of what did and didn't happen during that period. So I'm going to start with a quote that really kind of encapsulates a number of those themes and brings it all together as sort of an overview of experience. We were chasing medical professionals, paramedics, a lot of the routine appointments and tests, those kind of things fell by. Residents with dementia don't really understand why they're isolated, why they couldn't cohort. Our staffing dependency increased because people became less able. They were less independent because they weren't doing things. The low mood took a big toll, and people that are depressed generally don't do as much for themselves. And then, obviously, with the staffing impact as well, care wasn't at the same level that we would have hoped. So you can see there some of those issues about the kind of relationship with the outside health services, the feelings of isolation, and the impact of isolating people, and the impact of infection prevention and control measures on residents, all kind of encapsulated within that comment there. I'll talk a bit about the infection prevention and control policies. Generally, for the staff that we spoke to, the staff in the care homes were very, they were positive about their kind of engagement with those policies and their ability to enact them. And but they also experienced challenges, and I'll come back to that in a moment. But here in the first quote, it talks about, it's probably best that I don't read them all through. I'll kind of touch on instances of them, but they're up there on the screen for you to read. And the first one talks about how they engaged and implemented the sterilisation process and the process of hand washing, etc. And I'll also add at this point that we got some really interesting data about how care homes involved residents in that process as well, and got them involved in doing checks on staff, and just made it a more collaborative experience. I think the quote below is it's reflective of the issue of building and building spaces, and that how kind of challenging that could be, but also in this first point, the person shows how it helped them, how their building was spread over 3 floors, all of which could be accessed, but also how, often they're in older style buildings with nooks and crannies. They're not like hospitals, which can be sterilised in a more kind of systematic way. And they also spoke about how buildings kind of prevented the process of isolation. So they were all the policies that they had to work with, they were then grappling with their buildings and how they could implement them. Here we go. And so here you have a quote in the top there, really sort of highlighting the impact on staff. And staffing is an issue that came across, cut through all of these themes. Staffing was an issue. And in the first quote, they talk about people having problems because they couldn't carry their water around, they couldn't hydrate because they couldn't access the water while they were mask wearing near a resident. And then this resulted in a number of kind of illnesses and problems for staff. And again, so it's a bit of a vicious cycle with staff then going off sick. And there's another quote down here about the intensity of work and how the work intensified with a smaller workforce, which again, the vicious cycle led to more people being off sick from that. And the quote at the bottom there talks about people resigning around the time because of the workload and because of concerns around COVID infection. This all intensified the problems for the care homes. This one is really just trying to highlight how pragmatically how difficult it was to implement infection and prevention and control policies, especially with a resident population maybe with dementia. So the idea that you could try cohorts, keep COVID positive residents separate was a farce. It just didn't work. It was impossible. And the interesting thing here is it was seen as almost cruel because they didn't understand why they had to stay in their room. So, this was a big thing that came across, so I'm just adjusting my screen a bit. So this was a big thing that came across for the care homes. The guidance and legislation that came down to them came from a number of different sources, and they found those different sources confusing. It could come from public health, it could come from the local authority, and it could come from their care home head office as well, and as well from direct from government sources. And they often found them to be contradictory, and so they were always trying to think about what needed to be done and what policies needed to be implemented. The other thing was that because changes happened outside at a quicker pace, so for the rest of us who weren't in the care home environment, rules were relaxed maybe, and we could move around with greater freedom. So the families of residents interpreted this as increasing their access, and so but that wasn't necessarily the case for the care homes. But it increased the pressure on care homes to enable access when it really wasn't appropriate at that time. So they felt a lot of pressure from families at that time and a lot of confusion from the different sources of guidance and legislation. In terms of relationships with other bodies, particularly local authorities and other healthcare services, they were very positive about the support that they got from, in general, that there was positive about the support they got from local authorities, helping them interpret guidance and legislation, helping them give advice on infection prevention and control measures, and helping with the supply of PPE. I won't read all those comments out there, but they are very supportive in that context. The area they felt they could have done with more support was around staffing, and they felt really isolated and unsupported by wider care organisations and government organisations. You see here in this top quote here, when staff went off sick, it wasn't for 3 days, it was for 2 weeks, 3 weeks, a month or 6 months. Some people had to shield, and the staffing was crumbling, and we didn't have any help in this respect from the local authority or the government when we needed it the most to have bodies in work, and that was a really key point expressed by all of them. There was an incident, this further quote down here relates to feeling isolated from the healthcare system, where people from the healthcare, from primary care, from community care, weren't coming into the care homes in the same way. That increased their feelings of isolation, and they highlight this here, where we phoned for an ambulance and were told, you're not coming out because your resident is safe within a care home. I talked about this a bit, as I started the presentation, and I guess it was, so the care homes felt there was a kind of balance or a tension between infection prevention and control and the mental and well-being of their residents. And they felt at times that the balance may swung too far in favour of infection prevention and control, and that it took away it just made life too miserable for their residents, because they often didn't understand it, and they lost the communication, and they lost even the communication with other residents and some of the staff and their families that made their lives meaningful. And so I don't think I need to read through all the quotes, but you can see the power of them there. The second one is talking about the loss of touch and how the impact that had. And they say at the bottom there, a lot of the residents said they didn't really care so much about the virus anymore because they had such a low quality of life at one point. And I suppose what maybe we'll come back to in the summing up is just the need for a bit more autonomy maybe from care homes to be able to kind of balance those interests of mental health versus infection prevention and control. Okay, so the loss of people coming in, oops, sorry, I'm losing all control. The loss of people coming into the care homes from other healthcare organisations really increased the work that care staff and nursing staff within the care homes had to do. And all our care homes spoke about how they kind of, I suppose, upped their game in a way, their staff took on new roles and became more proactive in doing things for themselves. And in the second one there, you can see that it had a very positive, they felt it had some positive effects in terms of staff being more proactive in the kind of social aspects of the work they did with the residents. And in the second quote there, they talk about having reduced psychotropic medicines in the longer term. These are so that kind of role expansion went on during COVID, but has carried on into the post-COVID period. I will just. Are you happy for me to do this summary bit? Yeah. So in general, the overall finding from us was that the practices and the behaviour that we identified within care homes, both quantitatively and qualitatively, did not show any indication that it contributed to the particular death rates that you found in Baines here. And maybe that, and I know that the work that Paul and I'm sorry, I've forgotten your name, spoke to earlier, maybe gives some more insight into that in terms of changing preferences around place of death towards the end of life. The biggest challenge that was experienced during that time was the staffing shortages. The building layout and structure mitigated against some resident isolation policies. Looking forward, there's the point I made earlier about the care homes would like more autonomy to be able to balance their infection prevention control measures alongside psychosocial well-being, which became overlooked during that period, they felt. I think some of the issues that came through that we saw around frustration from the care homes was to a certain extent around communication, and so we kind of advocate to support and maintain lines of communication to reduce the feelings of care homes feeling abandoned and reduce the confusion caused by multiple sources of information. And just to conclude, these are the people who are involved in the work, the three of us here, including Rebecca and my colleague Celine. We had input from Jeremy Dixon at the University of Bath, who's got a long-standing interest in research around social care, and the team from Baines, Karen, Alice, Joe, Judith and Paul. And myself and Teresa are very happy to take any communications. I mean, we're happy to discuss now, but in the future, if you want to get in touch with us about this, do so, and our details are there, and Paul has our details as well.
Well, thank you very much. That's a very comprehensive piece of work that you've undertaken. So, panel, I'm sure there are plenty of questions. I'm going to kick off with Kevin and then Liz.
Thank you. Yes, thank you for the report, and it's good to know that there was nothing drastic that came out of it that we were overly concerned about, hopefully. On page 28, there is a list of recommendations from the report, and I just wondered whether or not, who actually is responsible now to ensure that these points are acted upon and that things will move forward in a better way.
What's the...
I beg your pardon, it's the report that we got, so it's probably Councillor Vaughan. I don't know whether it's your good self that's going to...
So who's responsible for implementing
Sorry, we've got
recommendations?
lots and lots of microphones on, so I don't know where the camera is.
Is that okay, Chair?
That's better, yes. Would you like to answer the question?
Yeah, thank you. And it's a really important question. So the work is already been contributed to and shared with our colleagues in adult social care who are most closely involved in working with our care homes. So after this meeting, which is where our kind of is reporting to, it will form part of going forward with that alongside our health protection colleagues in public health. And it will be through that route, and it may be that it would be helpful to have, that's the route it will go through. So Karen Green is the closest person to that. Karen's one of the people involved in the work, and working through that route and ongoing planning into just wider planning around infection prevention control rather than specifically pandemic planning. That will be the kind of route of their just ongoing work with homes. And that's within Suzanne's team. Karen's situated.
So will we actually get an update report on sort of what is actually happening and how this has been, these particular actions are being taken forward?
You can, Suzanne.
So what we will do is we'll take it through probably in our transformation update, not June, but the next one after that, just as part of our transformation update, we'll take it through that way and give you feedback of where we are with each of the recommendations.
I think that's in September. Okay. Yes, of course.
Outside Baines, going forward, we will aim to publish the paper from this in a mixed method, in a policy-making journal, and we'll use kind of ArcWest dissemination strategies to kind of make the most of our findings, and so that they feed into policy at a wider level as well.
Yes, thank you, because I don't think all of these findings are going to be unique to Baines, and also Baines may not be able to deliver them either. Kevin.
Just two other points, bless you. One is around the how the care homes are involved taking this forward, and the other thing around the ICB and whether they are particularly undertaking research in the area of risk factors for spread of infections and controls for future. So sort of around how this is being moved forward with the care homes themselves, and secondly around the ICB, please.
So we have regular meetings with the care homes, all of the care homes, not just the care homes that we contract with, but also the other care homes, which are private care homes. And through that monthly, I think it's their monthly meetings, if I'm right, we pick this up all of the time, and just with the culture, the leadership, infection control, all those areas are picked up in those regular meetings. What I would say about, from the ICB's point of view, we have a joint approach to oversee the care homes and the quality of care and infection control. And we have we have a worker from the council and one from the ICB who actually visits the care homes. And if it's RAG rated, if we're particularly concerned about a care home for infection control, then we will work with that care home and support them. And we've been doing that for a long time. It's tried and trusted model.
Is there any way of deviating from, or part of the discussion, it might be to come? It was suggested that you know there was things that were being done that were against what was the benefit of the people concerned, particularly the residents. How much autonomy would you be able to set out yourselves around care homes and how that is done in future?
Difficult because CQC, each of the care homes are inspected by CQC and governed by CQC. We work with CQC around that. So there are, there are certain areas that there isn't much flexibility about. I would say around infection control, and with the support of Becky and her team, that we focus in on that regularly. But not everything is within our gift. The compliance coming from the regulator is really important, and we support the regulator with that. And I talked about we have a risk approach in the same way that CQC has, so we'll know the care homes that are a risk and which need greater support, and we'll also know the good care homes. I feel we're very privileged in Bath because we have a range of big and smaller and medium type homes. I think, if I'm right, just over 77% are rated good or outstanding. We obviously want more people to be in outstanding. We have one or two, and not more than that, who require improvement. So we're constantly working with the homes to make sure that they achieve the best for the residents. And each of the homes, and I'll give an example of our own homes here run by the council, there's a lot of leadership and co-production done with the residents to hear their voices and their thoughts on whether it's food or the environment or the quality of the staff. And there's regular surveys done, and each of the care homes actually do that.
One supplementary on that, please. Just a quickie on
I was just going to add, I think maybe you're referring to this difficulty there was between the guidance being that people had to be kept isolated versus the social cost of that. So focusing on the physical health, well-being, and not thinking about the bigger picture. And I think that is quite, that was something that came from central government, really. It was the policy that came down through public health, and we were told that we needed to implement that, and homes were told they needed to implement that. Now, I think this is the sort of thing that should be reflected on in the COVID inquiry. So when, looking at that and coming up with guidance for future pandemics, which maybe look at that in a more balanced way, given the learning that we've got from this.
The subsequent point was really around the bit about, it seemed to suggest there was almost a need for individual care home plans themselves rather than a blanket approach. And how is that being fed back anywhere, and will the report link into other things because it's done through the National Health sort of system?
Yeah, we are working with the COVID inquiry. We've had to put a report in for the COVID inquiry. But the inquiry, and Becky will say much more about this, the inquiry has key themes, and it's working with local authorities and ICBs about feedback, and they look at the higher risk areas that they want to be involved in. But I'm hoping that the recommendations around some of what you've talked about was, because we had I'm sure Becky will talk about it, but there was a standard approach to visitors, for instance, and there was a standard approach to PPE, and it would be difficult for at that time, and even now if there was another infection, or even though we manage infections quite well, it would be very difficult for us to go against the national standard. We will go with the national support. So it doesn't allow really the providers or the care homes to do as what they think is best practice. We go with the evidence. And it doesn't always feel right for all of the care homes, I have to say.
I think it's also important to remember that there was very confusing advice that was coming out, you know, sort of almost on an hourly basis as well. Becky, sorry.
Thank you. I just wanted to add a couple of things just to build on what Suzanne was saying. Absolutely, as Suzanne says, we're working with the national inquiry, but just to put that in context, as is every other local authority. So we've not been approached individually. So we are working with them through adult social care or through public health or through the role of the local authority, through the breadth of its functions to support people during COVID in the national inquiry. That was the main thing I wanted to say. And also our officers, whether they are in adult social care or in public health during the inquiry, yes, we absolutely had national guidance that needed to be implemented, but we worked in a very collaborative way with our care home managers to really see how they could use the breadth of whether it's their estate or their staffing to be able to put that guidance into practice. So although it was national guidance, it was very much that collaborative, what does it mean for you and your care home, and how can we best support you and your care home to make the best situation for your residents as safe as possible. Thank you.
Thank you. Yes, I just wanted to, I guess, emphasise that point about working collaboratively. I think as an authority, and I was the council leader at the time, we made a conscious decision to, you know, to have one set of guidance that for everyone, very much aware that there was this confusion that was going around. So, thank you. Paul, I think you're, sorry, Liz, and then Paul.
Thank you. The aim of this report, we're told, is to note its findings, and I was a little bit disappointed that we didn't get recommendations. Now we've got learning points. Maybe it's semantics, that the learning points were actually recommendations. And the aim also was to find out why did more people die in care homes in Baines than in similar local authorities with similar demographics. So, and we don't really have an answer. Now, maybe Paul and Teresa, you'll tell me there isn't an answer. There isn't one simple answer. It's a collection of things. And we're told all sorts of things like staffing shortages, the layout, more autonomy, all these things. And I just wondered, are we able now to put all these things together and have a plan? Now, Suzanne, you've mentioned transformation, and I think, Becky, you've mentioned what we are going to do in the future. But do we have a plan now, based on all this research, all the things that we've been involved with, that when the next pandemic occurs, that our residents of care homes are going to be protected, the staff will be protected, and will be able to protect the inmates? So that's my question. Thank you.
Becky.
I'm just going to pass over to Paul, but I just wondered also whether Paul might want to pick up on your point, Paul and colleagues, pick up on your point about do we have an answer to that question or not, because we just have to remember the report that came out last year as well. So I don't know if you just wanted to respond to that first of all, before then picking up perhaps with Suzanne around the plan going forward.
Yeah, I can. I mean, I think what we have is from those three objectives, we now have these two studies and that other report that I think give us our best sense of what has been going on. So for that first question, as you're saying, of why we had higher death rates in our care homes, I think the most important thing around that is we had lower deaths from COVID-19 in our population overall at that time, lower than the England average. And we had higher death rates in our care homes, lower death rates in our hospital. And we had one of the highest care home death rates but one of the very lowest hospital death rates. And in fact, if those two things had averaged out, we wouldn't be having the conversation at all, probably. Now, the pattern, as Councillor Bourne had mentioned, that pattern of having a higher percentage of deaths occurring in our care homes and a lower percentage occurring in hospital than the England average had been there for the last 10 years. I wasn't aware of that before looking into this, but that's a pattern we see in Baines. We see more people dying in their usual place of residence. And Baines, in the last, they're not doing those figures currently, but in the last figures looking at that, Baines had the second highest percentage in the whole of England, out of 150 local authorities, of people dying in their usual place of residence. So that could be at home or a care home. And if you look at the national figures around where people die now, the percentage of people dying in hospital is going down every year for the last decade, and the percentage of people who die in their normal place of residence is going up. So there is a switch going on, which I would suggest is due to more care planning, people choosing to die in their usual place of residence. Now, choices in the pandemic were difficult, and the research colleagues from Arc West showed it. Sometimes choices were different, but the fact that the pattern had been going on like that for the previous decade in Baines, and that our overall death rates and our COVID death rates were lower than the England average, suggests that was not necessarily a negative thing. It was reflective of that overall pattern. And then the last piece around that bit that I would just add in terms of understanding any other evidence that suggests something about people staying in care homes rather than in hospital, is that when you look at our hospital attendance rates, so from care homes, either emergency admissions via the emergency department or just attendances at the emergency department from care homes, so it's just unplanned care coming from care homes, Baines has a much lower rate of escalating people from care homes into hospital than our neighbouring areas. And that fits. So in terms of if we've got more people dying in a care home and less people dying in hospital, that's either coincidence or it's part of that planned care when people have said, if I become very unwell, I don't necessarily want my care to be escalated into hospital with the risks that might entail for people who may not benefit ultimately. It might not make a difference to the outcome. It might, but it might not in that circumstance, and they would rather stay in a care home. So that picture, I believe, is probably, given everything else the studies have shown, where there weren't lots of specific factors like discharges from hospital or care home staff sharing accommodation, none of those things seem to show an association within the care homes in Baines. And some had lots of deaths, some had very few deaths. So you would expect if there was something going on, it might have shown something, even though there were limitations, which we've acknowledged. So I think that other pattern seems to provide the best overall answer as to why Baines had a higher rate of deaths in our care homes compared to other areas. And it's because people were more likely to stay there, less likely to be escalated to hospital in an unplanned way, and less likely to die in hospital as a result. So that's where our deaths occurred, in line with our overall deaths that happened pre and post pandemic, and will still be the same picture now. I don't know if that helps, but sorry, quite a long answer. But
could I ask a supplementary? Because nationally, the picture was that patients were discharged from hospital into care homes. So could that have happened in Baines, that patients went from who were unwell in hospital and then discharged into care homes, and then that led to the spread of COVID and ultimately to more deaths?
So that's one of the things, that was one of the risk factors that was looked in the study, and it had a slightly jargony term. I think it was called discharge to access, and it was looked at whether patients being discharged from hospital seemed to cause that. But there was no association, was there, between having those patients discharged from hospital. There was no association with that and having a higher number of cases or a higher number of deaths. Is that right? So we found no evidence of that. So although that was a possibility, it turned out it was almost the opposite. It was the reason there were a higher number of deaths is because people weren't escalating to hospital. It was actually the other way round, if that makes sense in a way.
But could I ask, have we a plan to deal with a pandemic because obviously there will be more pandemics. So just basing our information on all the research that's been done, I think probably, Becky, this would be your area, would it be? Have we got a plan? Are we ready for the next pandemic when it comes, be it looking after our patients in care homes or hospitals, but obviously in this instance focusing on care homes?
I think there's a number of elements to that. I think some of the learning from the National Inquiry at a national level will inform planning going forward. Certainly in terms of BANES, we've done quite a lot of reviewing how we manage collectively with our partners throughout the pandemic and what some of the learning is therefore for us as a local authority. So we have a document called Living Fairly with COVID, Living Safely and Fairly with COVID, and part of that planning is around if we needed to escalate, because we did have a big outbreak or pandemic in BANES, how would we build up and escalate? A lot of that, though, we do need is dependent on a national plan, because if you're talking about testing and you're talking about access of PPE and access to tests and access to funding for people who aren't able to go to work because they're required to self-isolate, a lot of that is national. So certainly at a local level, we are learning and have learnt what we can from the pandemic, and do have thoughts and plans in place about if we needed to step up. But it's a dual thing, because we do need the infrastructure that would come nationally, and that's what part of the National Inquiry is about, going on from there.
And I think it's reassuring to know that our findings are being fed into that national report. Paul.
Thank you. First of all, I'd like to agree with Liz on her question about the recommendations. I would very much, as you know from previous meetings, I really think that we ought to be having positive action recommendations, not just note, 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 listen, listen, listen. So if you want to think about a 2.3 during the rest of the debate, I'm happy to second a motion on having something action and positive happening. Questions. You said the data is fully anonymised, and that's absolutely correct and proper practice, and we should know that unanonymised data anyway. But if you found any outliers, were you feeding that into the officers so that they could do special work on places that were either very bad or very good? So before you anonymised it, for our purposes, how did you report outliers to staff?
So in terms of the qualitative data, we tried to build up a picture of the responses that represented those five care homes. So we didn't really there weren't too many outliers that really kind of disrupted those main themes that we presented there. There were kind of odd comments, etc., but we wouldn't but it wouldn't be within our remit to feed back to individual care homes, because that would undermine the ability of individual staff to talk freely if we then went back and said there was it was more about building up a picture across the care homes rather than a picture of individual practice. I mean, you might want to speak to the outliers in the statistical.
So for the quantitative data, so it's a combination of different data sets from BANES Council, and we've had a lot of discussion with them about, so during our data processing, before we started the analysis, we've actually looked at the data about the completeness and about the quality, and if we have questions, we actually fed that back to them. It's like, this ID number, something, is this number correct? And then we've had that conversation with them, and then they corrected that, or they said that is the number that was submitted to us. So we did those quality checks from the very beginning with BANES Council, and then finalized the data set. So that was incorporated within our processes. So they know if there's something going on with the data that's been submitted to us for analysis.
When you were seeking your pool of homes to look at, obviously each home has its own decision making, but did you get any outright refusals to even negotiate, even talk to you or concentrate on your, or were people all interested in the process and the reasons for it?
We invited people to come and talk to us, and So we were reliant on people, and we did that through various mechanisms, through Karen and colleagues of Paul's who sent out emails, but the emphasis was that people should contact us if they were willing to take part, so that they felt that it was their choice to be able to take part, rather than being told to take part by the local authority or any other body. So we didn't, other than the informal conversations that I had with care homes who expressed an interest and then declined usually because of lack of staff time or resources, we didn't really have much feedback on why people didn't take part. There was some, with a couple of care homes, there was some sort of discussions with their head office about whether it was okay, and again, that never really presented as an obstacle. But it wasn't really within our remit to have that kind of knowledge. It was on people to contact us, and that's the way we tend to do that kind of research, so that people aren't pressurised into taking part from their, not their employer in this situation, but just from any kind of governance or managerial sort of organisation that could be seen to be making them take part. We wanted it to be purely voluntary.
Thank you very much for that. I'm not sure going forward whether we should allow people the option to opt out of data research, but that's a different matter. You said in your presentation that 71% were female on one of those slides. Is that because 71% of the residents were female, or was that out of kilter with the male-female mix in the homes?
So those 71% and 84% females, those are the percentages of females among people who have COVID and people who died. So it's just, that's the proportion of the females among those who have COVID and among those who died with COVID.
The question is it representative? Is that what you mean? Sorry, so does that reflect the underlying composition of the care homes? Is that right? Was that the question? Yeah.
In terms of representativeness, yes, that is representative of all the care homes here in Baines, because those numbers reflect all of the cases of COVID infections and deaths in the care homes during that period. So that's September 2020 to February 2021.
So what was the percentage for the males then? Because you highlight the females, and I just wanted to know, is that higher or lower than for the male residents?
I think what it's saying is, I think we're slightly talking at cross purposes, but I think what it's showing is that of those cases, 71% were female, and of the deaths, 64% were female. What we don't have, which I think is what your initial question was, is, for example, 71% of residents in care homes, are they female? In which case it just reflects that. Or if it's 50-50, that looks like an overrepresentation of cases and deaths amongst females. But I think, our adult care colleagues might be close to it, but whether we have a higher percentage of females I can't remember the demographics, whether that's an overrepresentation or just reflects the underlying. We don't have that. Anonymized and... Yeah.
We don't have the data with regards to the proportion of, the demographics of people in care homes during that time. So we ask for that, but because the council only has data for people who are paid by the council to be in the care homes, so we don't have data for private patients, so we actually don't know. Yeah, so that's
One next question is on social isolation. What lessons are we learning of this? Because obviously, if you're in a care home and you're elderly and then you're suddenly not allowed to speak to anyone, and you can only speak to relatives over a gap of 100 yards or whatever the distances were, what lesson are we taking from this, and how are we learning about dealing with these sort of infectious diseases, but also dealing with the psychological trauma of being locked away if you're old and infirm and have got dementia? So are we learning any lessons from that type of thing, other than just sort of saying there was an issue with social isolation?
Paul might come in on a moment here. But I suppose what we're doing here is just giving a voice to those care home staff who saw the situation on the ground and saw the impact that those policies were having on the mental health for their residents. How we kind of process that data and how we work with it going forward, I think that's for all of us to think about, really. I mean, locally, for Paul and the team to take that forward, and for us as the researchers and wanting to give voice to this, we will, like I said earlier, we'll try and work within the avenues we have to kind of publicise this and think about ways we might do it differently going forward.
Yeah, I probably can't add much, but I think it's a really important question, isn't it? And it's probably not dissimilar to the kind of question we might ask in a school setting. You know, that balance between, as was described earlier, the kind of physical protection of trying to avoid people getting COVID-19 and the kind of mental impact of bringing children off school, for example, and keeping children at home. That now, people are reflecting on whether that was the right thing to do. And it's probably similar, isn't it? Getting that balance between the physical protection from a health protection point of view so that residents don't get COVID-19 with the mental and emotional impact of being isolated. So that probably is more of a almost like a national level discussion and approach that needs to be enhanced, because as Suzanne said, there's a limit probably to it's really difficult, isn't it, those kind of brokering for a care home worker with a family as to how to make the best of slightly restrictive guidance. It puts staff in a really and that's that trauma as well for staff, isn't it, that they're having to do things they may not even feel are right for their residents, but they know if they don't do it, they're now acting out of line with policy. So I think there's two things, isn't it? One is that policy thing, trying to share those findings a bit more widely, and the other then is how to be more pragmatic in local planning.
That's all right.
Carry on.
Yeah. So if we remember back to the start of this, the national government was, at least by everyone that I speak to, opinion, at least 2 weeks late in taking this thing seriously. Going forward, is there going to be a best practice guide that we can put forward from our point of view to the national debate about how future infections, because as Councillor Hartman said, the one thing's for sure is that this is going to happen again, whether it's in 3 years or 4 years or 5 years. So we don't want to be taken by surprise and suddenly end up ordering lots of PPE for our mates' mates and things like that. So how are we going to make sure that this best practice guide, we contribute to it, and how do we address the issue of taking something this seriously and locking down society? Is that the sort of thing that you're putting into your recommendations?
A lot of this will come through the national inquiry, and so the modules that we've already as local authorities been asked to participate in have asked for examples of good practice, examples of innovation, whether that's been a focus through the Association of Directors of Public Health on public health practice, or through the local authority more widely, or through adult social care. So we have absolutely been asked to give, all local authorities have, examples of good practice, things where we've had to be innovative and had to do things differently because areas were thinking on their feet right at the very beginning, and really using the best knowledge they had to make very quick, urgent decisions. Did you want to come in, Paul? Did you say? No.
So a final question then is this thing on contradictory advice. When we had a nightly film show with those 3 blokes standing and talking to us, and 2 of them were highly qualified, and one of them was winging it. How do we get controversy? How do we get to a situation where we had contradictory advice going out all over the place when we had a nightly information set with 2 of the most qualified people in the country, they're the people who had all the background information. So how did this contradictory advice thing come about, and how do we what steps we put in place to make sure that going forward, that when this happens again, this confusion is minimised.
Becky, can you put your microphone on?
Can you hear me okay now? Yeah, I think it's a really challenging question and a really, really important question to ask. Again, going back to the National Inquiry, I hope that that's something that they will, I would expect that's something that they would pick up. I think messages did become clearer as we got more further into the pandemic, as guidance became clearer. At the beginning, the availability of guidance for care homes specifically wasn't there. There's a lot of infection prevention and control guidance, but it was spread across lots of different documents, so there was a job and a task then to try to bring that together. I think key is communication with our organisations, with our providers, with our care homes in this situation, which certainly in Baines we endeavoured to work really hard. That may sometimes inadvertently have led to confusion if they were also receiving messages from other parts of the government or other government departments or their own employers. But I think a key to any communication is having messages that are agreed corporately, agreed across the different sectors. So for us, that was public health and adult social care. Public health absolutely linked back into the into our Public Health England, as it was at the start of the pandemic, in order to take national guidance and look at what that meant for our care homes. So I think there are different elements to it. There will always be possibly some degree of mixed messages sometimes when things happen at different paces in different parts of the system, and when you've got political input and you've got scientific input. That's an argument for government to work out how it makes a political decision based on scientific evidence, because politically a lot of other considerations have to be taken into account. I don't feel I've quite done justice to your question. It's really important, and I think key for us locally is about that ongoing talking amongst ourselves, between ourselves, but in this situation, public health and adult social care, and with our care homes, so that those relationships are there.
I'm sure that will come when this presents 2.3 recommendation at the end.
Thank you, Becky. I just wanted to just clarify one thing. Sorry, I know I'm pushing in front of you, Joe. Which was, am I right in hearing what you said around that you didn't know what the makeup was in care homes? Because I was just given some information about from the ONS, from Office of National Statistics, which says that in 2021, the average was 23 women to 10 men in each care home, in care homes, sorry. So that would actually fit in quite well, I think, with your overriding statistic of around about 71% of women then dying in care homes, because also there would be a greater proportion of women in care homes anyway. So I don't know whether or not that's something you were aware of, or if I just missed that moment when you said that.
At the time that we did this study, so the data came to us in September 2021. We didn't have that information. Yeah.
Because that was the census information, as you said, and I know it took a little while to feed through. Okay, good. Right, Joanna.
Thank you very much for this report. The use of ethnography and those voices that you've given centre stage to, essentially, in that report are really powerful. And again, picking up from what Councillor Crossley has said about needing recommendations, I'm just wondering if there's some way that we can use those voices in that recommendation, because they are so powerful. I'll give you an example. I have a resident in my ward who moved to this part of the country because she had a parent in a care home. Her mother died during COVID and she was not able to be with her, and it still traumatises her. So this piece of work is really powerful in the sense that what you're essentially saying, and that was very useful to hear from Paul Scott, explaining that actually of the deaths at home and moving and through. And I understand that that the percentage was higher because of the situation, not because the deaths were caused by COVID. So I think we're clear. But the real human impact of local people's lives, of being in a care home, of not having your loved ones with you, of surviving your parents dying and not being there when they died, will traumatise a huge number of people for generations. It won't just sit that it happened. It will be passed through generations of people. This happened to us, and it was awful, and we don't want this to happen again. I think, again, Councillor Crossley was alluding to the situation at a higher national level that was not acceptable, that a lot of us have found problematic. So therefore, going back to the recommendations of how we pull out these voices that you have through ethnographic research, and we go back to our community and say, how do we support you generationally from here? Because it is a trauma, and we need to identify and accept this trauma has happened and will be in place for generations, would be the point I want to raise first.
Does that mean you've got a second point you want to raise as well, Joe?
So I kind of spoke to it a bit earlier, but I'll just go back to the earlier slides that Teresa put up about who we are and what we do. We are part of a University of Bristol, but we're part of ArcWest, and the whole kind of rationale of what we do is that we want to see changes come from research, and we want research to have an impact. We don't want it to sit in a kind of academic journal and, you know, gather dust. And so we haven't really kind of mobilised that part of it yet, because the whole thrust of this was pulling the report together and getting it to yourselves. But going forward, you know, there'll be a conversation that the team here at Baines will have about how to use those findings. But we will also work closely with we have a communications unit, and we will work closely with them, and we will do our utmost to make sure that the research that we've done has an impact and finds a voice in policy-making circles. And quite what that is at the moment, I can't say. But what we won't do is like stop here. And so we will endeavour to do as much as we can to make sure this influences policy at a national and wider level. Sorry, Teresa, did you want to say something there?
I was going to say that we do have publication and dissemination policies in Bristol, and particularly in ArcWest. So we are going to publish this, and then we would have communications related to that publication. And hopefully we get to the point that we talk to Policy Bristol and we try and get this more disseminated in terms of policy. But as John said, it's like we've just got this report sorted and then presented, and then we'll go to the next steps after this.
Thank you. So maybe one of the recommendations is that this report doesn't stop here. That how do we take this forward from here, and do we bring it up again in some kind of way and see that has happened? I guess my other thought is we know there are excess deaths, and we still haven't underlined what that is and why that has taken place. We know a lot more people have died than has ever died before, and I'm no wiser at the end of this on that issue, and I still think that this committee needs to bring that in some capacity. And I guess the wider question too is we need to protect our population when there are outbreaks of whatever, but at what cost? And there's finance is always brought into this, but we don't ever sort of bring into the issue of the personal cost that it causes people emotionally. And I think there needs to be some criteria for this, and we don't seem to have that in place. You work in social science, in adult care, in care generally, yet I don't see a barometer for what that looks like, and I'd like one. And there is real pain in the community over what has took place, how their lives were impacted beyond just what happened too with in care homes, because it had an effect elsewhere. Thank you.
Thank you. I just saw nods. Yes, I know, Leslie. I just wondered if Paul wanted to respond.
No, I don't. I mean, I think it's a really important point. I don't know if I have a specific point. I mean, it could be an area of further research, to be honest, because it is an important one, but I don't actually have anything specific to say.
And to acknowledge the point you're making very strongly. Thank you.
Of course, Suzanne.
I suppose what I would say is that our care homes are experts in infection control. They're, you know, it's still going on today, whether it's COVID or it's flu or any of the other infectious diseases. They are the experts, and they do, as we do as a system, work across with health and social care and with public health, you know, how best to support them. So this never stops for us. Maybe one of the, if there's any good thing about COVID, was that it has helped us to work much better and we've had a lot of support from public health in particular on how to do this right and well. And I also want to just take this opportunity to thank the care homes for the work they've done. You saw some of those stories, how that felt for the management team, how that felt for the resident, their families, the care staff, the commissioning teams, and how well they all worked together. It was a really hard and isolating time, and it was nothing that we could say we learned from. We had no experience of it. It was really new to us and new to all of the care homes. So I think it would be remiss of this panel not to thank the providers of the care homes, the staff, the residents and their families as well for the great work that they did to support, because they did lots of great work, whether it was a drive-through or it was just a wave at a window. It was really very difficult. So I think the panel also needs to just to make sure to formally thank all the people who were involved in supporting the care homes, the resident and their relatives.
Thank you. I think that's going to be built into the recommendation.
Sorry for reading your mind.
That's okay. Everybody's doing it today. Leslie.
Yes, thank you for the report. I'm not sure that it's got us any place further forward, as we're hearing from the comments being made today. Did the research look at the movement of staff between hospitals and care homes, and did that make any kind of an impact? I know at Western there was a whole ward closed down because of that, where staff were working in care homes as well as in the hospital. And Suzanne, you just picked up an issue on infection control. Where I work, infection control, you know, they're like the thought police. You know, you have to follow what they're saying. And I would hope that is consistent right across. I mean, you did say there was need for some improvement in some places, but I'd like to see that as part of the going forward plan. And with regard to staff, you mentioned in the report that they'd had to learn different skills. You know, will they be recompensed for that? It's not enough just to thank people and give them a clap, really. And are we then building on that experience that they're gaining from that time? And with regard to the social isolation, I mean, we're seeing the problems that we're having with young people that have been locked away for a couple of years with COVID, and some of the things that are coming out through our youth services. I read something recently about care homes saying that they felt it was very wrong to keep people divided away from their families and their friends, obviously. So it's going to be really important that we pick that up and look at how we deal with that. But if we mix that up with infection control, where did infection control slip? Because, you know, it doesn't matter whether it's DMV or whether it's HIV or whatever it is, you know, surely that has got to be of a prime concern. Thank you.
Would you like to pick up on the agency study?
With regards to the question about whether we have data on staff working in hospitals, unfortunately we didn't have that kind of information with us. So we have the information we have about staff is whether they are in shared accommodation and the staff turnover, but we don't have any other information about the staff.
Sorry, I don't know, were you going to add anything more? I wasn't sure.
I don't think so. But I think we did try to look at agency staff, use of agency staff, didn't we? But I don't think the data was available, so it wasn't possible to include that. It was often just quite difficult to gather the data, unfortunately, just despite huge amounts of effort from Karen Green and others, colleagues in adult social care and some of our colleagues in public health. But that one about agency staff wasn't possible.
But I recall from the pandemic, during that time, that it was an issue that was, did come up quite often, and I hope your point about staff shortages generally is going to be made nationally, because I'm not quite sure whether when you have those conversations with any of the care homes, if they identified where these extra staff are going to come from.
No, they didn't. But sorry. No, they didn't. And that, but it was kind of the point of it was really giving a voice to them and their frustrations around that.
Yeah, and I think that's well recognised. Thank you. Ruth, and then I'm going to turn to Liz for that recommendation.
Okay, thank you. Now, yeah, I was just a couple of little questions because I'm curious. You said for the qualitative survey that you had responses from 5 care homes, and that you had written to many more. So I'd be interested to know what was the total number. So to know how many didn't take up your offer, and the fact that I think it was written somewhere that that often quoted was that they were just too busy. So that says a lot in itself, doesn't it? So it'll be also really interesting to know, to bear that in mind about why they didn't respond and what you would have found out from them if they had. So and the other thing, so I'll just sort of say the other question I had was about the average age of people dying during this period in care homes. I think it's been rounded up to 89, but do you know what the equivalent is for elsewhere, sort of nationally? Was that a higher average age? Because I know that's not the only cause, but it is a factor, isn't it, towards in COVID deaths, the age factor. If there were more older people in these care homes than nationally during that period who died of COVID.
I don't think we know the answer to that, do we? We don't have that data. What we do know about Baines is that we have a significantly higher number of beds that are nursing home beds per head of population in Baines than residential beds. So people who may have other additional clinical needs, nursing needs and so on, we have a higher percentage of those beds in Baines, which means potentially we could have more older people in our because we have a larger base of beds available to support people. So I don't know the answer, but it's an important point just in terms of potentially we have people who were in need of additional kind of clinical support from nursing and other kinds of care. So that's the only answer I can give, but I don't know the answer. Well, I mean, we may have an answer from colleagues, but I don't know.
Well, it looks like Alison's got the answer.
No, sorry, I don't have the answer to that. I was wanting to respond to the question that Ruth raised about staff shortages and the reasons why care homes didn't participate in this research. And I think it started just as we were coming out of the pandemic, and at that time there were an awful lot of staff shortages in the care sector. I think during COVID we really struggled because of Brexit and the fact that the source of care staff that we'd had been turned off. It was difficult to get people locally. Since then the government has changed the rules and a lot of people are coming from other countries further afield, and that has really improved recruitment in care homes. But actually, obviously, because they're now changing that, I think it's going to become more challenging again. But I think the reluctance to participate was genuinely about the pressures to keep the show on the road and maintain services in care homes rather than people not wanting to take part. And that was largely due to staff shortages at the time.
to that earlier point about the numbers we contacted. I mean, the emails went out to all of the care homes in Baines, I think, didn't they, Paul? So that would have been 70, was it 70? Some care homes, I think it was. And then when we decided to go beyond Baines, we contacted care homes through what's called the Enrich Network, which is part of the Comprehensive Research Network based in the west of England, which is so the CRN, the Comprehensive Research Network, have started to build up a network of care homes who have expressed an interest in participating in research, and we put the message out through that network then. So there was a lot of you know, we didn't get much take-up. Ideally, what we would have liked is to have a number of expressions so that we could have then sampled different types of care homes from those expressions, but we ended up talking to people who just expressed an interest to us. In terms of the strength of the work, you know, that is an issue, but in terms of the strength of the work, all of the messages or the voices that were coming through from the care homes were quite consistent. It wasn't that they were wildly different, which made it feel like, well, we've either selected 5 outliers or we've got a kind of a good picture of the perceptions and experiences.
You may, because I've also met...
That was, yeah, I noticed of the 5 that 4 of the 5 also offer dementia care, so that was, I think that was something that interested me particularly, but thank you.
Thank you, Ruth, and thank you for your answers too. Right, I'm going to turn to Liz to pull together some sort of resolution to move us forward, so actually this doesn't just stop here.
Thank you, Chair. If you look at number 3, the report, if you look at the recommendations, number 2, the recommendations, and that we are asked to do 2.1, 2.2, I think we are agreed that we would like to put in some recommendations ourselves as a 2.3. However, to do this, we have to pass a resolution, so we have to resolve the following. So, Kerry, I believe, or Dina, I believe, I will be reading out the recommendations. I mean, it's mainly the learning points which we feel should be recommendations, and then we have to vote that we are resolved to accept these as recommendations, and then they go in as recommendations. Okay, so here I go. The first one was about is 310, and it's very much about staff shortages, we're looking at the fact that emergency staff were needed. So staffing shortages was the biggest challenge identified by the care home staff, and we would urge the local authority to develop contingency plans that will enable care homes to be supported with emergency staff cover for pandemics and other unexpected events. Would everybody be happy with that? Is that okay? Okay, the next one is isolation and infection control. For better isolation and infection control, building layout and structure must be developed or could be developed and regularly updated to control infection in particular buildings according to their settings. It's a bit clumsy there. I'm trying to put it into a recommendation, but I'm sure that can be put properly.
We could finesse it after.
Yeah, absolutely. The other one was more consideration and autonomy given to care homes. That's our recommendation, to enable them to find the right balance between infection control measures and the psychosocial well-being of their residents. And that brings in, I think, your point, Joanna, about the well-being of local residents. And I think it's worth saying about diminishing the feelings of abandonment and isolation. So it would be to support and maintain lines of communication to diminish the feelings of abandonment and isolation, especially around policy and guidance, where we had multiple sources of information leading to confusion and uncertainty. We also felt, I think Gina was recommending, that we should thank the researchers for producing this report and the recommendations we're now adopting, but that finally and very, very importantly, that we should recognise the huge effort of support staff in the work that they did over and above in the care homes during the COVID pandemic.
Yeah, I'd just like to add a couple more points, actually, if I may. I think one was recognising the awful time that care homes experienced. And then the last point, which actually possibly should be at the beginning, is that our recommendations are in addition to any other recommendations from the National COVID inquiry as well. So are those allowable? And
I think Paul might have something.
thank you, yes. Thank you, yes. And there was one more, which was that we welcome the author's offer to bring a further report, an update report on the implementation of recommendations to our September meeting as well. So, okay, are we happy to vote for all of those en masse?
I think we just need, for Mark's benefit, for the minutes, just to run through that we've got those.
Do you want to forward those to Mark so that we can... Are you okay, Mark?
I've made quite a number of notes, Chair, but we obviously have the recording of the meeting that I can clarify things with yourself and the Vice Chair if needs be.
Lovely. In that case then, everybody almost happy to vote?
I just wonder about family members. Did we have something in there about family members? That seems to be the one thing that wasn't on there.
Was that implied with one of your recommendations?
Special communication.
Okay, all right, Bruce.
Could you just read out the bit you proposed about the thanking support staff? Because I was just wondering if there was a bit we could add on to that as well. Could you read that a little bit? Do you have it still? No.
Liz, could you put your microphone on?
I haven't actually got it written down, but I was hoping that Mark would take it down as I was reading it out.
Okay, it was something about to thank the support that staff.
It was thanking all the people that worked in care homes, but also recognising, what an awful time it had been for everybody.
Yeah,
as well.
I was just going to say something, maybe add something about actual personal sacrifices they had to make, because I know that some of the care staff physically removed themselves from their families so that they would, be protecting their families and particularly the care, or they actually lived in for a long period. So personal sacrifice, if you could build that in somewhere.
I remember what I just said. We said we wanted to recognise the huge effort and commitment and sacrifice then of staff.
Okay. Right. So is everybody happy to vote on those recommendations? All those in favour? Okay, I say that's unanimous. Thank you. Right, we now move on to our last item, which is our work plan. I know there's been a couple of items that have been mentioned throughout this meeting which will be added onto that, not least that update on COVID sort of measures to be implemented. We also are expecting a report on triage and to include repeat prescriptions. Have I missed anything there?
Do you want me to run through them?
Yes, please. Thank you, Gary.
Okay, the items I've made a note of is Councillor May offered to bring a report on the work that he's leading on regarding care experienced people. we've also got an offer to add the 3SG activities and potentially bring representation from 3SG to a future meeting and talk to us. Lucy talked about the dental bus work taking place and bringing that in a future update. Culver Hayes School update was requested to be added to the forward plan. And I've also got a note there around primary care access improvement programme and avoidable emissions to A&E, as well as incorporating those into future updates from the ICB.
Thank you. So is there anything else anybody is aware that we've either missed from the meeting or would like to add as well? Ruth?
Yeah, well, it was something that was included in the, I think it was the report from Lucy Baker about the suicide prevention strategy that's being about to be signed off shortly, apparently, by the BSW Mental Health Thrive Board. But there was a small paragraph. It'd be good if we could have something, more information about that, please.
Thank you. Yes, we will. And Kevin?
I don't know whether I might have missed it in Kerry's list, but the Public Health were going to update us on the whole system health improvement work in July. And there was the SHU survey, hopefully results coming out, whether that's later in the year, September-ish, whatever.
Well, it's not called the SHU survey anymore.
Sorry, no.
Could I
the
come,
old SHU survey.
It would be fantastic to bring both of those here. Am I okay to come back to you? It would be really helpful if I can come back to you with a proposed date. I just need to talk back to, because they both need to come to the Health and Wellbeing Board as well.
Thank you.
So that's those two items, health improvement and the school survey. Thank you.
Joanna?
Is there something about the joint task force on school streets? I know I've been told that it sits in climate emergency, but it is a public health issue, so surely there should be some joint working between.
Kerry, do you have an update on this?
Yes, school streets is coming to the May meeting of Climate Emergency Panel, but we're going to talk about issues that are cross-cutting at our chairs and vice chairs meeting next Monday, which we can add that to for the discussions.
And I assume, Joanna, if there's a need to put somebody from this panel onto a joint task group, you would be first in line. Thank you for the volunteering. Kevin?
Yeah, thank you. There was mention a couple of meetings ago about the ICB's Children and Young People programme, to bring details of that to us, and particularly to include in that their work around mental health and social media. But they have an actual Children and Young People's programme, apparently, which I think Paul may have suggested to bring to us.
Well, if it's ready, maybe we can bring it to our next meeting, which actually focuses on children. Perhaps it could be part of either Paul May's update or Laura's. Okay, well, anyway, we'll find a way of putting that in. Any other suggestions? Otherwise, I'd like to thank everybody for your time, and my original target today was to finish this meeting half an hour ago, so I'm slightly disappointed in myself, but thank you.